Oh, mi era facile.
Good morning, everyone.
Good morning and welcome.
Good
morning, sir.
Good morning. We're going to continue with our research program, which we started last week. I'm going to have a quick recap because possibly we may have one or two people that are joining us, and probably they were not in the previous class. And because of that, possibly people may have some challenges in following up with what we are doing today. So if you don't mind, I will take probably like 15 minutes to rush through the discussion we have last week. And I think it's also of benefit to even those people that are with us last week. So if you don't mind, I think we should take it that way. So what do people think?
That's okay, sir.
Yeah, so all right, we're going to go through, it's the same slide, but then I'm going to rush it a bit faster than we did last week, so that just to quickly remind us of what we have done. Let me see if I can share the slide, then we continue. I'm just having a bit of challenge in sharing the slide. I don't know what's going on. Okay, I guess we can see the slide, can we?
Yes, it's coming up.
Okay. Is the slide on?
It's on.
Okay, all right. So we're gonna quickly go through the activity we did last week so that we carry everybody along. So we actually initiated it by starting to define what research is all about. And primarily, we understood that a researcher is somebody who can think out of the box. We stated that research is seeing what everybody else has seen, but then thinking differently, thinking what nobody else has thought of. We've given quite a number of examples regarding that. And we look at different definitions that were presented by different researchers regarding what is actually research. And a key of one of these definition is that of Clifford Woody, who defined research in a very diverse way, looking at different stages of arriving at a conclusion at a research. And one of it is formulating hypotheses and coming up with objectives. collecting, organizing, and evaluating the data, making deduction out of the data you've collected and reaching conclusion, then testing the conclusion to determine whether they fit the formulating hypothesis and all that. So all the stages of research were captured by Clifford in his definition of a research. So research is actually a diverse thing, and it is systematic because it has stages. And the beginning of every research is for you to develop specific objectives of what you want to do in a research. Again, we look at features of a research, which we say a research must be systematic, like I mentioned earlier. It has to be logical. People should be able to relate with what you are saying. You should be able to look at it that it's making sense. So there should be sense in the research. And it should be empirical. Conclusion should be based on the evidence you gathered in the conduct of the research. So you should not come up with something that cannot relate with the information you gather. So every conclusion you're going to make about a research should be centered on the evidence you're able to arrive at from the field. There should be a significant objectivity in a research. That quantifying the findings is actually very possible. It should not be too subjective, such that it's difficult for people to be able to relate with. However, when we talk about objectivity of a research, like I said last week, in a research, there are two major research, like we say we have quantitative, we have qualitative. A great deal of all quantitative researches should be objectively relatable, while a significant number of qualitative research are essentially subjective. We talk about being able to replicate a research is what makes a research sensible, meaningful. You should be able to reproduce it based on the methodology that is given by the researcher. If you say this is the method I use in arriving at these findings, then any other person who decided to use the same method should be getting the same result or nearly the same result. So if that cannot be obtained, then that would be also a big problem. Then we say in the research, generalizability is a key when it comes to quantitative research. We say we approach quantitative researches with the intent of generalizing our findings, because oftentimes we only take a sample of a population to conduct our research, and the intent is for us to extrapolate our findings to be able to apply it to a larger population. So, but of course, when it comes to qualitative, the intent is not generalizing the findings. So generalizability applies significantly to quantitative researches. We equally say that research should be transmittable. You should be able to carry the findings we are able to get in a setting and take it to another setting, and with similar, let me say, characteristics that your findings should be able to apply to them. If it is a low-income country, then the research should be applicable to other low-income countries, except where there are significant differences between the two settings. So research should be transmittable. We mentioned this. Quality control should be instilled in a research. We talk about cost effectiveness, and when we are defining cost effectiveness, we did not stop at talking about the money being spent in conducting a research. We say including time and other form of resources are considered as part of being cost effectiveness of a research. And we say all well-designed and conducted research has potential for application. So you cannot do a research and it has no any place to be used. And usability of a research is applicability of a research. Then we did talked about other areas, particularly we talk about research in health targets the access to cutting-edge treatment, potential for more effective treatment, that's the basis for research, monitoring of health situation, access to expert care. These are opportunities that actually comes with research. Why do clinicians conduct research? We say they do that to validate intuitions. They have their own intuition, so they want to validate such intuition. They want to improve the method of practice. They want to make demand. It could be because of the demand of job. And again, of course, they want to gain popularity and come up with patents. That could be the reason for conducting research. We mentioned how do we develop, what are research questions and how do we develop research questions? We say research question can come from your curiosity, attentiveness to happenings around you, being able to become someone who reads a lot, an avid reader. It's easy for such person to come up with research question. Then, of course, collaborating with mentors or co-researchers. Co-research enthusiasts can also help you in generating research questions. And what are research questions? They are the basis, the root and the foundation of every form of a research. The question you are asking about, why is this not this? Why is this going this way? Why is it consistent? Why is it not consistent? Why is it black? Why is it blue? Why is it white? And all that. So those questions are what we look at when it comes to research questions. Then we did mention the basic, do not let methodology, we said your methodology should not drive your research. The research question. So you should be able to come up with research question, not necessarily until it is after you come up with a question, then you develop the methodology along the line to solve that problem. So we said clinical research questions should be formulated to meet certain scientific criteria. This is summarized as FINGER. And we say the F in FINGER means feasible, interesting, novel, good, ethical, and it should be relevant. So these are the key things that every research question must have this quality. Is it feasible? Can we actually answer this question? Is it interesting? Does it attract attention? Do people actually have interest in what we're trying to do? Is it actually new? Is it something that is distinctive? Nobody actually has done it. Or probably you're trying to expand the knowledge of a people. Novelty can come from different dimensions. Do you want to change the method that people are used to, and therefore you're coming up with a different approach to get the same answer? When you were in primary school, secondary school, I think, some of us who are very interested in mathematics, your teacher will finish teaching and he taught you a particular formula of arriving at a particular, at solving a particular problem. But then because of your curiosity, you feel that there should be a different way. And in a way, you come up with a different method and you're getting the same answer. And when you submit it to your teacher, he tends to be amazed that this is very good and he approves of the method you are actually presenting to him. So that's a kind of a novelty. Changing the direction of something can equally make it to become novel. It should be good. It should be ethically acceptable. It should be relevant to the need of a people. So all these are qualities of a good research question. This is just a continuation of that. I think. Okay, then we move into looking at the content of a research question, particularly when it comes to quantitative researchers. And we said your research question must present the population you're working on, should indicate the type of intervention you're trying to introduce, should create a sense of comparison between one thing and another that is going to be in your research. And the outcomes to be researched should equally be clearly mentioned in your research. So we call it a PICO. So a good research question, particularly for quantitative researchers, and most importantly, experimental one for that matter, should have a PICO quality. We mentioned three major types of research questions: quantitative, qualitative, and the mixed method. We give a number of examples of the difference between qualitative and quantitative. And clearly, we are able to say that to differentiate the characteristics, we say quantitative, they test hypothesis, and we do not test hypothesis in the case of qualitative. We talk about the research design. We say quantitative are usually structured, and we say qualitative are not structured. We talk about difference in terms of the participants. Quantitative, many participant representative of the group from which they were chosen. So probability sampling are used to get a representative sample. But in the case of qualitative, we are not very interested in generalizability. So for that reason, we do not need a representative sample. In fact, to make it short, we said all literally participants in qualitative researches are selected or recruited using what do you call it, purposive or judgmental sampling techniques. Okay, data collection in terms of these two. The data in case of qualitative are numerical, while that of qualitative are narrative, and so on and so forth. Again, we say the role of the researcher is not deeply into the research, is usually detached, particularly at the point of data, outcome measurement. The researcher is detached from the main research. This is to avoid bias in data collection. While in the qualitative, you cannot detach the researcher from the main research. Hardly, basically, because the researcher is the one who formulated the interview guide, and therefore is actually the rightful person to interview the participant or be engaged to be part of the focus group discussion if that is the means of collecting data. One of the contexts, we say the context of qualitative and naturalistic, which means it comes naturally from that individual. While in the case of quantitative, they are manipulated. We talk about what is manipulation of variables, and in particular, we talk about dependent, independent, and the fact that when you have two groups or more, you try to allocate subject at random to these groups. Oh, this is the same thing about the research designs. Okay. Now, then we talk about quantitative designs, and we say there are two major ones, experimental and non-experimental. The investigation of causal effects through manipulation of independent variable and control of extraneous variable is what primarily defined experimental designs, while non-experimental, the investigation of the current state of variable or relationship other than causal effects, what actually define non-experimental studies. I gave example, and I think we did an exercise regarding this, talking about quantitative research. And when we share this slide, you may go through if you happen not to be in the class last week. Okay, differentiating the three types of experimentals. Randomization is the major thing that defines a good true experimental study. While the quasi-experimental is the main limitation is because there is no randomization. So clearly, the difference between true experimental and quasi-experimental is randomization into groups. Then we have single subject where we say we can do a pre and post assessment of a single group or a single individual. That's what defines a single subject quantitative design. We now extended our description of descriptive research, where we talk about descriptive research is undertaken to describe answers to questions of who, what, where, when, and how. So this is the major focus of description, where we say who are the population, what are the specific disease factor or whatever you want to search on, where is about the setting, when is about the timing, and how is the occurrence, how does it occur, and all that. It is desirable when we wish to project to studies findings to a larger population if the study sample is representative enough. So in descriptive research, we say there are two classifications. It either is cross-sectional studies or longitudinal studies, and there are other branches, observational studies, and some of them at the end of the day end up to become either cross-sectional or longitudinal. But these are the major description, cross-sectional or longitudinal. We actually gave a couple of examples in our class. So I think we should go to, okay, we talk about panels. Then I think we discussed this, quantitative designs. Then we move into some common clinical quantitative research designs. And we started with therapy, prevention, stroke intervention studies. And I think we've exhausted that. So in therapy, prevention, and intervention and prevention studies, we say when a study is actually designed to come up with a therapy, for example, a new drug, a new treatment, a new exercise approach. For those who are into exercise therapy, you may have, let's say, intermittent exercises, continuous exercises. You could have self-management exercises, home-based exercises. You could have telerehabilitation exercising and all that. So all for those kinds of exercises that you are introducing, probably the novelty is probably you are introducing into a different group that this exercise has not been introduced to. For example, telerehabilitation exercises for elderly population in Kano. So if there is no such research that has been conducted, the population introduced to the population is probably what is going to be unique about it. And you should be able to tell us why is it unique in that population. For example, let's say education level, let's say environmental circumstances, let's say the kind of cohesion in the family and all that. So all those reasons that you can present and all that. And it could be from any population. So the form of exercise, what of self-rehabilitation? You can say the study you're doing is about self-rehabilitation, let's say using video, using audio, and all that. So to promote such kind of thing that is completely a therapy to remedy a particular condition could be a form of exercise. Intervention exercises, therapeutic exercises can, I mean, let's say therapy form of intervention, therapy form of experiment can equally be an intervention to remedy a particular situation. So depending on how you tailored it, you could also come up with a research that is completely targeting a prevention. Let's say, for example, in a locality where you actually discover that women are dying at early age, let's say, particularly because of during labor. Let's say during labor, they die you have a lot of maternal mortality because of at the cost of delivery. And you now say this has to be tackled, this has to be prevented. So you now say probably you feel that most of the women, the type of feeding habit, let's say nutrition in that locality is that they are used to certain kind of food, and you made an assessment and you realize this food is not nutritious, or probably they have some dietary habits and you feel this dietary habit is actually affecting the population. Somebody is playing with us here. Okay. So the dietary habit is the reason why you think women are dying from labor, and for this reason you feel that something has to be done to reduce the mortality rate. So for now, you now decided to come up with, let's say, a kind of a distinctive nutritional content, and you selected a group of women that are pregnant, and these diets will be distributed among those a selected group of pregnant women, and you have a group that remain the same. They are not actually being introduced to the diet, And after a while, they went into labor, and you're looking at mortality rate at the group of those who are under your diet solution or nutritional solution, and those that are not under the solution. So you wanted to check which group is actually doing better. So along the line, you realize a great deal of those who participated in the dietary solution, wherever being introduced, survived, and they seem not to have the challenge that exists in those who are not involved. So that automatically tells you that nutritional solution could be a very good solution to the mortality issue in that setting. And though you now look at that dietary solution as having two qualities. It is an intervention to stop the mortality, and it's also a preventive study because it prevents increased rate of mortality, maternal mortality in that particular setting. So there are quite a number of other ways to approach that. So a study could actually have a therapeutic effect. It could have an intervention effect. It could also have a preventive effect. So it depends on what is the direction of the researcher. What does he intend to achieve? What is the objective of the study? And on and on and on. So we actually exhausted that significantly. We talked about the study very well. So today we shall be going into studies of diagnostic quality. The main reason for coming up with the study is for us to be able to determine or diagnose existence of something. I'm going to give you an example before I start this. One of the things that we do a lot, particularly if those that are involved in neurological, neurophysiotherapy, you often come across spasticity as one of the major challenges in rehabilitation in persons with neurological challenge, either a pediatric case of cerebral palsy or an adult case of Parkinson or an adult case of, let's say, stroke, and so on and so forth. And the two major tools we use in assessing spasticity are the Ashworth scale and Tardieu scale. Some of us may probably be hearing about Tardieu scale for the first time, but then we're not going to be discussing that because this is not a neurology class. Future, we shall be looking at diagnostic tool in neurological studies. That will be coming any moment from now. But then let's focus on this. So these are the two major approaches to assessing spasticity. We have Ashworth scale and we have Tardieu scale. Now, the Ashworth scale takes a very short time to be administered, and but the problem with it is that it's actually too subjective, and a number of researchers criticize it, though it is the most common way of assessing spasticity, either in cerebral palsy or in the case of adult neurological conditions. But the thing is, while we know about this problem of its subjectivity, and again, when it comes to Tardieu scale, it's so unpopular. So particularly in developing countries, but it is more objective than the Ashworth scale. It's more robust than the Ashworth scale, according to quite a number of other researchers. Now then again, these two tools, where are they coming from? Both of the tools are not developed in Nigeria. They are actually developed in the West. And for this reason, probably, according to you think that they may be missing certain things in our domain. And for this reason, you feel that there should be a different tool to assess spasticity that is actually domesticated, that has a quality of recognizing our differences. And for this reason, you develop a new tool. Now, what are you going to assess with the tool? What you are interested in is assessing spasticity. So to determine either severity of spasticity or the presence of spasticity. And if your tool is able to give us results, we are able to identify spasticity with it, assuming it takes a shorter time, assuming it has objectivity rather than subjectivity and all that. And we are able to use your tool to get it. So it becomes a study that is diagnostic. I'm going to give you a second example. We did a study on stroke-specific quality of life questionnaire. And one of the questions that is in this questionnaire is, I think, is about using your belt as well as using buttons in fixing your cloth. Now, this study, we did a study among stroke population in Kano, and one of the things you hardly see in the male is you hardly see people with belt here. So we use our, let's say, trouser lace to tie our trousers here in the north more than we use belt. We do hardly have a cloth that uses button very often. So we hardly use shirt. So now, at the end of the day, this tool is not developed in Nigeria, it's not developed for people in the north. So if we want to use this tool and we leave those questions that are centered on the use of belt, centered on the use of putting on buttons, it's not going to capture our population. For these, instead of using the tool the way it is, we have to adapt it, adjust it to suit our people. So therefore, questions that are centered on belt have to be replaced with using, let's say, a trouser lace, if that term is correct, and many other things like that. So we have to domesticate some of these tools to be able to diagnose condition here than for us to always rely on Western tools. So if you do a study and it's the main target of the study is for you to be able to diagnose something. So such kind of study, we call them diagnostic studies. Studies that are aimed at diagnosing something, or they are coming up with a diagnostic test to assess a particular or confirm the existence of severity or confirm the existence of a particular condition. So we say a study intended to evaluate a diagnostic test with respect to whether the test provide reliable information about whether the subject has the disease or condition of interest. What I will add is also test the severity of condition of interest. When the utility or benefit of a diagnostic test is evaluated as a management strategy, it should be categorized as therapy, intervention, or prevention study. So let me explain this. When the utility or benefit of a diagnostic test is being evaluated, look at that. If the utility, the use of that tool, or the benefit of the tool is what we want to check, then our study is not diagnostic. It becomes a therapy or intervention or preventive study. So you could actually have a study that what you're using is a tool, but then because the intent is utility, the use or the benefit of that test is what you're looking at. So it's no more diagnostic test. There's diagnostic study. It has become a therapy or intervention study. And I think this is easy to understand. So study of diagnosis to diagnostic test, like I said, in doing this, the gold standard of this is for us to ensure that an independent or max blinded comparison to reference. So you should have outcome assessors using these diagnostics tool must not be aware of the two or more groups that you're trying to test the use of your tool on. So it shouldn't be like the researcher is the one that came up with diagnostic tests who wanted to check, let's say, goniometric measurement, and somebody decided to say he has what he called Abba goniometer, or let's say Abbastic measurement. So Abbastic measurement is also for him to measure ranges of motion, but using a technique that probably, let's say, he's going to use he's going to take a picture of a joint, and from there he is going to make some few calculations, and he will arrive at the joint range of motion and so on. And based on these, he will make comparison with that of goniometer. So if something like this is going to happen, people who are using the Abastic method and those that are using the let's say goniometer, before making the comparison, you cannot be the researcher that came up with the tool known as the Abastic measure, and you are the one that is now taking the Abastic measurement, and you are the one taking the goniometric measurement, and you are the one telling us at the end of the day that the Abastic method is better than the goniometric measurement. This will definitely be biased. So it will be better. You came up with the tool. Thank you for that. But then let's have different assessors who are going to come up with the assessment, and we can make comparison between the two tools. And probably at the end of the day, we should be able to say whether this one is better or the other. An appropriate spectrum of patients like those in whom it will be used should be involved. If, like I said, the Abastic and goniometric measurement, if this tool is supposed to, the Abastic method, let's say it is developed for persons with osteoarthritis, no matter the location of the arthritis. If it is developed for osteoarthritis, either of the shoulder, of the knee, of the ankle, and all that, if this is what the tool is developed to, assess, you can now start using the same tool to say that I want to assess persons with stroke. I want to assess pediatric cases and all that. So the particular group of people that this diagnostic tool is actually intended to be used to assess should be involved in the research. Should then get a different group of people, and you now start telling us a different story. For example, you see a situation where people will say they are trying to do a pilot test of a particular particular intervention, and all the patients recruited or all the persons recruited to participate in the pilot do not have the characteristics of the primary population they wanted to use this the intervention on. So you tend to understand, I have a problem with that, because now you tested your pilot on a healthy population, and you want to implement the study on a disease population. And you say, since the healthy population showed characteristics, acceptance of the intervention, you now are expecting the disease population to also have the same response. That would be erroneous. So when doing your pilot, take a sample of your pilot from a population where the larger study is going to be implemented. So this is key in doing your things. The reference standard applies to all patients regardless of their diagnostics test result. What is the reference standard that you're setting for your study? Then it should be applicable to all. Inter-observer reliability of the test evaluated if test or evaluation is being used. So this is also key. Like I said in the last discussion we had, I said inter-observer reliability is a key thing when it comes to evaluation. There are certain tools that their inter-observer reliability is very poor. In that regard, it is always advised that you don't have a number of assessors. I gave you we just mentioned something about Ashworth and Tardieu scale. If the inter-observer reliability of Ashworth scale is usually very good. Now, the thing is, if I have a large population of subjects that are participating in a study, and it is not possible for me to have one person assessing the outcome, so I would therefore need persons that are well trained, of course, in the use of the tool, and those that are well trained in the use of the tool, if we make comparison of their findings, their assessment, we hardly can have significant difference in what A assesses in and what B is assessing. So inter-observer reliability is not large, is a lot reliable. And for that reason, tools that have lower level of inter-observer challenge or problem, it's okay if we have several observers, several assessors to use them. But in the case of tools that have a significant variation in inter-observer reliability, it is better you have a single assessor to reduce the problem of inter-observer reliability. What is it? A study intended to evaluate the etiology, cause, predictors, or risk factors for a disease or okay, yeah, we're moving to a different study. We are done with diagnostic studies. So we're moving to studies that are centered on etiology, harm, risk factors, mechanism of disease. So a researcher can set out with the intent of finding out what is the etiology of a particular condition. As far back, let's say about 25 or so years ago, I was in Benue State, and one of the things I noticed was that I was having a great number of secondary school students that present to the hospital with facial palsy. And it was so high that it was disturbing. So why are we having, and a number of them are actually ladies, young girls presenting with facial palsy, consistent, so large a number. And interestingly, we also noticed, where do we have this particular group coming from? They actually come from the axis where you have the two tribes, the two second tribes in Benue, which are the Idomas and the Igedes. So you have a number of them being sent to the hospital, Medical Center, Makodi, coming up with facial palsy, young ladies. And again, interestingly, there was a lady who was teaching in a secondary school, and she was telling me that a number of times when you don't see a lady in the class, they tell you it's because her face has a problem. So it will be interesting. Of course, I was just on a short stay there, so we didn't do this study. I wouldn't know whether the situation remained the same. But then, why are they having facial palsy? What is the cause of facial palsy? So if a researcher is set out to specifically identify the cause of a particular issue in a population, that would be very, very important for us to know. There was a case we also noticed in the postgraduate school some time ago. A student presented, did a study about mortality. He observed that in their area, both male and female die at a younger age. And he just said he's a chemistry student, so he decided to do a study that I just realized my people are dying a lot and at a younger age. So he started checking the water content, chemical content of water, and he realized a lot of particles of lead in the water around that particular axis. So therefore, these studies like these are essentially etiologic in nature. They want to find out what is the cause of ABC. If a study is set out to check why is this happening, what is the cause of ABC, we call this etiologic studies. And again, it could also be a study that is looking at risk factors for ABC. So there are studies that are centered on determining risk factors. I have a student currently doing a study in trying to check risk of a particular cardiovascular disease among women in a big setting. So again, I have a student who is also doing a study trying to check the risk of cardiovascular cardiovascular condition in prison inmates and all that. So you can see, looking at factors at different settings, either risk factors, either harm of a particular condition, either cause of this, a researcher could center his study on this. Mechanism of a disease. Let's say one of the things that knock footballers out of their profession is actually knee pain, knee injury. So assuming, and by the time you now look at what group of players often find themselves terminating their career earlier, their career end very fast. And one person actually observed that those who dribble a lot, they are strikers and they dribble a lot because of the fact that they turn their legs several times to dribble. It's probably the reason why a number of them, their career end very fast. So, but then what is the mechanism of the injury for persons whose career end very fast? Because probably because of dribbling, because of knee injury and all that. So if a large study will be conducted to determine the mechanism of the injury, then we can immediately after determining that, we could go into preventive study. So one study can actually go in, that can lead to another study. You did a mechanism of injury assessment, then later you can say, okay, can we now introduce a preventive study to see if this new preventive study can actually help us in reducing the chances of having such injury. So it discusses findings in relation to the biology, mechanisms that may underlay the association that were found or attributable to existence or presence of a condition being investigated. So we can do it in form of a cohort, a case control, a cross-sectional study. All these can be applied in etiologic studies. It should have a clearly defined group of patients with measures to ensure that they are similar in all important ways other than exposures to treatment and risk factor under investigation, exposures and treatment, risk factors and outcomes measured in the same way in both groups. So when you set out this kind of a study and you have several groups, the measurement pattern should be the same across the groups. I define a case control study there, and I say case control assemble subjects on the basis of the presence or absence of the outcome of interest. Subjects are then evaluated, usually retrospectively, for the presence or absence of an exposure or exposures, and we've already discussed issues around cross-sectional study. So again, like we said in the previous ones, we talk about assessment of outcomes stroke objective stroke should be done in a blinded way. If you are going to do this study, we do not have, as much as we can, in literally all the studies we are mentioning, we want the researcher to be significantly blinded to the outcome so that we reduce the level of bias that may interfere with the findings. Assessment stroke exposure, assessment of exposure stroke treatment risk factor that is objective and maps to outcome to the extent feasible. It is not in all circumstances that we have the assessment, the assessors being blinded. We reduce as much as possible the level at which the interests of the researcher interfere with the findings. There are situations where we cannot do otherwise than for the researcher to be involved in outcome assessment. For example, in administration of questionnaires, and who's going to administer the questionnaires? Sometimes, if it is researcher interviewed, or let's say self-administered. Even if it is self-administered, you realize that it is still the researcher that is going to distribute the questionnaire. So in a way, he knows the person he's given the questionnaire. So that could mean that it's not literally possible to take away the researcher from certain form of data collection. But as much as possible, there must be a lot of integrity put into the research process. Follow-up complete and long enough to answer the study questions. So whether the study is intervention, prevention, diagnostic, or etiologic study, there must be enough period of follow-up. And what do we mean by follow-up? Let's give an example with an intervention study. Somebody decided to see the effect of exercise on cardiopulmonary, or let's say on COPD, and this patient the subject are supposed to exercise for a period of 4 weeks. So he assessed their, let's say, their respiratory parameters in the prior to the commencement of the exercise process, and he put down the assessment. So after 4 weeks of exercise, the assessment was, the measurement was reconducted, and which means he has a pre-intervention measures and post-intervention measures. So measurement before and measurement after. But then there is always the basis for treatment is for the person to get well, is for us to be able to cure the condition. So we should be able to know that after these 4 weeks, without any form of intervention, the result we get that we consider to be positive, for example, all the patients or a group of the patients are healed from their condition. They are all doing well. So we'll be interested to know that after a period that they are not actually involved in these exercises, is the effect sustained? Is the result the same? Are the patients still doing well despite stopping the exercise? So the period we allow them where they are not taking exercise, where they are not taking our medication, if it is medication, where they are not involved in the intervention anymore, but they are living their normal life, that period that we allow is the period that we call period of follow-up. But if we want to set a period of follow-up, the minimum of period of follow-up is usually 3 months, but the most adequate is actually 6 months of follow-up. So the patients were assessed at the beginning before the exercise, they were assessed immediately after they completed the exercise, and they will now be assessed after they have stopped the exercise, either 3 months later or 6 months later. And the perfect period to do this follow-up is 1 year, 12 calendar months. So if we now go back to now check the patient and see this thing, you have already stopped the exercise, but let's see if you are still okay. So we are now going to make comparison between baseline, that is prior to commencement of the intervention, outcome, that immediately after finishing the intervention, and follow-up, which is 3 months, 6 months, or 1 year after completing the exercise. If the effect we are able to get, let's assume our patient deteriorated, they move backward. That is to say, even though our exercise is effective when they are doing it, if they stop this exercise, they are in trouble. There will be a relapse of the condition. So we probably are going to make recommendation that, yes, the exercise is effective, but then it cannot be sustained until when the exercise continues, which means it's a positive findings that, yes, if you want to live a good life, continue with your exercise. That's it. So the second issue is when we now realize that patients actually have similar situation. Like, let's say after 6 months, there is no decline. The difference between the outcome, which is post-intervention assessment, and the final assessment, there is no significant difference. which means even though the exercise has stopped, the patient are still, or the subjects are still doing well. And you can have the third situation where even though the exercise has stopped or the intervention has stopped, the patient are even better. Now, in such situation, that is to say that probably the fact that the patient are already doing well after the intervention, they continue to improve along the line, with or without the exercise. So in a way, follow-up is key in most intervention studies. So then we have studies that are prognostic in nature. A study intended to evaluate the expected outcome for subjects with a particular condition or treatment, including studies that evaluate the risks associated with particular tests. There should be no intention of drawing conclusion regarding causal relationship between the condition and the outcomes. If causal inferences are to be made, it should be categorized as etiologic study or intervention study. Now, what are we saying? What prognostic studies are doing are basically trying to evaluate outcomes in terms of chances of recovery over time. Chances of recovery over time. Now, what is the prognosis of this condition? What is the likelihood that the patient will survive from this condition? Now, we are not looking at what will make that individual survive, but we are looking at factors around survival, factors around improvement. So if the factors around improvement are being assessed, then it becomes a prognostic study, looking at chances of person doing well, looking at chances of somebody recovering from the condition, looking at chances of somebody living, not dying from the condition, looking at decreased morbidity from the condition. So factors around that, if that is what we are examining, without looking at what is going to make them stay long, then it is a prognostic study. But when we now are looking at what are the things that will cause them to stay longer, then it becomes an etiologic or sometimes even interventional study. So we should know these as well. So it can be done in a cohort, a defined representative sample of patients sample at a common, usually early point in the course of their disease. So you get the early part of the condition before you start assessing basically prospectively to see chances of survival. Follow-up patient complete and long enough to answer the study question. So you can follow patient for a long duration prospectively to see chances of improvement, survival, and all that. So objective outcome criteria applied in Marx fashion. So the outcome criteria for assessing prognosis should also be objective and often, like as recommended in previous ones, the individual making the assessment should be blinded. Adjustment for important progressive factors if subgroups are identified. If you have subgroups, in this group, what is the, let's say prognosis for persons that are living in the rural setting and prognosis for people that are living in the urban setting. But then you are looking at factors in the urban setting that will make somebody survive, and factors in the rural setting, but not making it causal. If it becomes causal, then it is changing. It's becoming etiologic. So it is preferable to try the validation of predictors of outcome in an independent group test set of patients, not the group in which the predictors were defined, although this is not critical in accepting the study outcome. So most of the studies we do that are predictive study are often prognostic studies. So determinant of this, determinant of that, determinant of this, they are not cause, but they are determinant of that thing. So they will determine whether something will move in this direction or it will not move. not a cause. So I don't know whether people, if you don't understand this, you can ask question at the end of the session. So we have studies that are descriptive and prevalence studies, incidence studies, prevalence studies, and all that. A study that describes the characteristics of a population without testing a hypothesis about the population or its subgroups are all descriptive studies. It is not checking, it's basically talking about the characteristics of the population. It is not testing any hypothesis. So such studies are known as descriptive studies, and they could be prevalence studies, which you could have incidence-based studies and all that. So that's the major characteristics of descriptive studies. So, and I hope people are paying attention to some of these descriptions that we're making, so that, explanation we're making, so that when we come to sessions of quick questions, you'll be able to attend to some of these questions very fast. Okay, population described is in sufficient detail for the study to be replicated. So what population are you working on? You cannot have a situation where you are trying to assess a particular population and it is not clear. Let's say somebody is talking about a population of women in a particular locality, and he wanted to see, let's say, rate of abortion, and he say among women. Now the thing is a little child, is she, let's say rate of abortion among females and all that, and there is no clear-cut definition of what age group is this individual looking at. What age group is he looking at? And that could be one factor, that he did not define the age group. So not defining the age group means that no matter how old a woman is, she's actually going to be part of the study, and no matter how young a lady is, she's going to be part of the study. So not having this clear-cut definition of the population may be a problem. And on and on and on. There could be different other examples. I can't quickly come up with some, but I think that the first example I give may assist. So subgroups, if used, if you have subgroups, it's good for you to talk about. I think in our last class we talked about changes in knee mobility with advancing age. So in a case where we say knee mobility with advancing age, we are likely going to have subgroups. Let's say the age of this to this, from the age of this to this. So you should have described those subgroups in a very clear terms. Particularly, what interval are you looking at in terms of the ages? Let that interval be consistent. That is when it is sufficiently described. You cannot say, let's say, from the age of 5 to the age of 15. In that case, you have, let's say, 11. The interval is 11, but then in the next group, you now say from the age of 16 to the age of 35. This is not good enough. You replicating such kind of a thing may be a bit difficult, but then when you have consistency in the interval, it makes it a lot easy. And let's say, for example, the first example I gave about women, and now we say those that are living in a, let's say, in a brothel dominated areas, and those that are living in a more decent environment. Is there a difference in terms of rate of abortion among women? So those who live in an area where you have a lot of prostitution, alcoholism, let's say a nearly less decent environment compared to an area where it's considered to be decent, there will be a kind of assumption that probably those that are living in an area that is considered not to be decent will have higher rates of having cases of abortion compared to areas where is presumably considered to be decent. Now the thing is, this could be just an assumption. You may be shocked that the areas people are considering to be decent are not as clean as the areas where people do not consider to be decent in terms of making comparison of rate at which women are involved in abortion. So these are things that should be made clear. So what are the subgroups? Oh, what of abortion in the rural region and abortion in the urban region? Who are more exposed and all that to abortion? So you subgroups like this is possible we could have them. Description of disease status or condition labeled in sufficient detail for the study to be replicated. So if we're talking about abortion, so you should make it very clear that this is what we're saying. What is the condition you are trying to assess? If you're talking about osteoarthritis, this is the condition we want to assess. If you're talking about COVID, you should make it clear what is the population and this is the condition. If you're talking whatever condition you want to assess, it should be labeled clearly. It should be so clear that this is the condition you want to actually assess. In most cases, inter-observer reliability is not necessary for us to focus on it when it comes to issue of prevention and descriptive studies. We do not bother too much about inter-observer reliability. Where we bother about that is, for example, if we are collecting the data using a particular questionnaire, and the questionnaire is actually written in Igbo, in English, I mean, but the population we are going to work on are actually Igbos. And the Igbos, there are dialectical differences, as I understood. In Anambra, probably they will be they will refer to a virgin using a particular term. But when you go to Enugu, the same virgin has a different name attached to it. In the north here, we have several types of these dialectical differences. But then, if then there is probably a common ground that people in Anambra will actually understand that they are referring to a virgin when they say this term, and this same term, when used in Enugu, they actually understood that is actually referring to a virgin. So now, if the questionnaire is actually in English, and you have the administrators of that questionnaire, the questionnaire is not translated into a common language. So when I am talking to a person that is coming from a particular region, and I'm trying to translate, and I use my own dialectical interpretation of that term, he may, and assuming the individual is not used to my dialect, he may interpret it wrongly and give me a different answer. Similarly, if I now interpret it to somebody who's coming from my dialect, he may understood it so clearly that he's going to give me the right answer. So at the end of the day, we are going to have issues with reliability of our findings. So, and that's why oftentimes when you have a questionnaire where it's going to be administered in a population or in a diverse population, or who are not probably language, not used to the language of the questionnaire. I'm not particular about saying it is English. It could be probably the questionnaire is written in Hausa and somebody wanted to administer that questionnaire in Ibadan, where they are predominantly Yorubas, or he wanted to use it at Enugu, where they are predominantly Igbos. And since he can speak Yoruba and he can speak Igbo, he decided that I would just be interpreting it using my language, using my own self. So in such cases, you may have issues at the end of the day. There could be a number of errors because sometimes you are translating it as this, another time you are translating it as something different. So the best way to do it, translate this questionnaire, get it validated. In fact, if possible, administer it to check reliability of the questionnaire. And at the end of the day, you have a very strong tool. The same way you read it to this first person is the same way you are going to read it to the second person if it is researcher administered. And even if it is in self-administered questionnaire, the same questionnaire is being shared. So there is nothing like using your own interpretation, because it's been interpreted and people will understand it better. I don't know. I hope this is helpful. Then we go into systematic review. Now we've talked about different form of researches. Now we're going into another research. Interestingly, when we talk about research, people look at the basic form of research designs and concluded that research ends with collection of data or going to the field to collect data. That is what is looked at, viewed as research. It's either it is a descriptive, it is an experimental study of all forms of description that I have given earlier. Many people do not understand that reviews are researchers. Reviews are equally researchers. So when we are trying to write, let's say, thesis or dissertation or project, undergraduate project, we only set out to copy and paste when it comes to the section they call literature review. And thanks to the laziness of we, the teachers as well, a great deal of us do not read the literature review of our students. A great deal. We are not bothered about what do they put together as their literature review. And for this reason, we now have a situation where people just copy and dump whatever they want in their literature review, knowing fully well that after all, my lecturer is not going to go through it, so why should I bother myself? So they package everything and just put it together. The second aspect is that you actually go out for literature review, not actually knowing what to review. You don't even know why we need literature review. In fact, there are a couple of students that actually feel that they don't know why literature review is added to a research. It's just too stressful. There is no need for it. After all, no teacher goes through it. Again, even me, myself, I'm just copying and pasting, and I don't even know the need for it. So, literature reviews are essential when it comes to research. In fact, it is the bedrock of every research. It is the bedrock of every research. Why am I saying this? If you are able to review your research, review the study that are conducted in the area you're conducting the research, and you do that thoroughly, you'll be guided from the beginning to the end of the research, and such that you have minimal to zero stress from the beginning of your study to the end. What do I mean? Number one, a great deal of students submit topics thinking that they are so innovative that they were able to come up with a topic, and no one has done this. To their dismay, when they submit to their supervisors, the supervisors quickly tell them how many researches have been conducted on this. What are you going to do that is different? In fact, sometimes they even tell you that go to this shelf, you will see the research by so person, check the project of so person is centered on this. So what are you going to do that is different? Why are you in such a mess? Because you've done little to zero literature search. So the chances of you coming up with topics that actually do not actually need anybody's attention because they've been attended to is very, very high, because you've not done a great job in your literature search. That's number one. So you can see it is a determinant of cleanliness, or let's say of ensuring that your topic itself is already being checked. You've actually been able to assess the level at which your topic has been exhausted. I mean, exhaustively taken care of by other researchers. So this is key. So everybody should understand that just thinking and coming up with a topic without proper research, a number of times I say, is actually a time waster and sometimes even suicidal, because you probably did not submit this thing until at the tail end, when you have no option than to make sure you submit something that you submitted it, and unfortunately you will still be sent back that, well, you wasted your time and you have no topic. Again, it also prepares you to know, how do you go about your methodology? How do you come up with a methodology? So literature review guides you towards, oh, what am I going to do that is different? Yes, I'm actually submitting this topic. I'm confident I'm going to submit it. But then I know that many people have done this research. But then because of my literature review, I know that the methodological approach that all of them are given it, for me, I don't think it is good enough. And therefore, I have a different approach to it. And that is why I still feel that conducting this research is meaningful. You cannot come up with such an idea until you are able to exhaust the literature to understand the methodology. The methodology has been adopted in previous studies to be able to conclude that, yes, the new method I'm coming up with will be better than the previous methods that were used by previous researchers. Literature also helps you to be able to explicitly discuss your findings. So when you concluded on what you're doing, your data collection, you finish your analysis and you want to discuss your findings, the rate at which you go into literature search will surely help you to be able to discuss your findings. Whether you are looking at it from the perspective of physiology, pathophysiology, or you are looking at it from demographic point of view, you are looking at it from diagnostic approach, no matter what approach you want to look at it from, your findings can significantly be discussed thoroughly when you have a good literature search. It expands your level of thinking. It helps you to be able to look at things in using different approaches to be able to interpret your findings. So literature review is something that enriches you in your discussion of your findings. At the same time, it helps you to conclude. If the conclusion in different studies is tailored towards a particular direction, based on the literature search and your findings, you can actually be able to say that most of the researchers concluded so. But actually, based on the findings of this study, we can actually conclude that this is our findings, and which actually probably deviate from what people are used to. I'll give an example. There was a time one of my students, undergraduate student, said to me that, "Sir, I actually don't know. I read it a lot. When it comes to stroke. But since we've been going to the clinic, one of the things I notice is that our patients are not fat. Our stroke patients are not fat. But the literature is saying that obesity is a very important factor when it comes to stroke. So how comes our patients are not fat? This is an undergraduate student looking at something in a different way. And I said, oh, I think the name is Kazim. I say, okay, Kazim, what we can do is this. Why don't you now say that you want to see anthropometric body composition in persons with stroke, so that you now report to us, what did you find? What is the body composition? And your major body composition is essentially you are looking at BMI. because he's an undergraduate. I want him to quickly finish. So it would have been better for us to say, okay, let's look at the body composition, looking at BMI, looking at body adiposity using percent body fats, percent body around body composition, and we'll be able to report and say that based on our findings, we do not think what the literature is saying about let's say obesity and persons with stroke is a common thing in our setting. So until we are able to understand that yes, the literature says this, but then our conclusion is this. So it's only when you do enough search of the literature that you enrich yourself that you can go into these. Okay, I think I've discussed enough about why do we go for literature review, and I wouldn't know whether there is one or two questions on that before I commence my discussion on systematic review. Let me take one or two questions from where I'm coming from. In fact, for the whole of the discussion we've had from today, if you have some few questions, please post the questions or you raise your hand and we identify you so that you can say one or two things before I proceed with systematic review. Quick one. So I'm listening. Any question?
Yes, Dr. Lawal.
Yeah.
Please, I would like to find out how inter-observer reliability is done. Is it subjected to any statistical analysis, or how exactly is it done? Thank you, sir.
Good. Okay, I'll be attending to your question immediately you ask the question, so that inter-observer reliability often is subjected to statistics. And in fact, the only way to handle inter-observer reliability is through statistical approach. We essentially get the data collected by each of the observer, and we now make comparison of, we do correlation statistics to check the reliability of the two or three or even more observers. So it's actually done statistically. Okay, any question again? Next question. I'm going to leave this for the next 5 minutes. I'm just going to attend to questions, 5 minutes. If there are no questions in the next 5 minutes, then I'll continue. And I don't think, I think before I continue, I will equally ask my own questions. So that it's a balanced thing. You're not only taking from me, I'm taking from you as well. It's been quiet, no questions? Okay, my first question, which is a straightforward one, is there any problem with the presentation in terms of speed or clarity that you want me to improve on so that the class will be better? I want that so that I know what to adjust, what to correct in the presentation, so that the participant will get it better. I don't want, I told you, teaching for a couple of years, for me, I don't think it's making sense if you have students and they are not understanding anything. Please, if you have issues with the clarity, with the examples, or anything that is not clear, please let me know so that I can improve on what we are doing. All right, thank you, Gloria. Afelomo, thank you. Okay. Okay, thank you. Thank you. All right. All right. Okay, so let me go with my next question so that now it's your own turn. In a simple term, what would you say is the characteristics of a descriptive form of a research? What is descriptive stroke prevalence form of research? What would you say is the main thing about the mainstay about descriptive and or okay? I think Mr. Habib. What is the major thing that we need to know? Uh, Sorry, colleague, I had just a brief internal problem. So please, can I see your responses now? Okay. Trying to. Okay. Do you have everybody got his signal back?
Yes, the signal is back.
Yes. All right. So good answer, Mr. Okeke. Yeah. So what is the major characteristic of descriptive stroke prevalence studies? Now coming, this I think we should have more responses. I think we should have more responses now.
Sir, can you come again with the question, please? The network is a bit bad.
Yeah, the question is, what is the major focus of descriptive stroke prevalence studies?
Okay, thank you, sir. I think the major focus, sir, is to try to explain the main characteristics or the situation of the condition or the situation of the subject matter you're trying to carry out your research on. That's to describe the main characteristics of the situation, either the incident, as in prevalence study, or to describe the occurrence of something in relation to the variables that are taken.
That's a good one. If you remember in the slide, I gave a very short description, and I think somebody tried to pick some part of it, where I said the first thing you start talking about is who, which means you're talking about the population there. What? You're talking about the condition. When? You're talking about the time. How? You're talking about the distribution. How does it go? So this is a general picture that describes a prevalence study, and it does not in any way try to say anything about cause and effect. So, and we, of course, somebody just say that. Then one other thing is that there is nothing like hypothesis. Now, let me, there is an aspect that I want you to understand in terms of when it says there is no hypothesis, because you're likely going to encounter a problem with some, let's say, external examiners. There are many external examiners that will come to you, whether you are an undergraduate or postgraduate student. And when you finish your research, they'll say, what is your hypothesis? There is no hypothesis in this study. To be frank with you, such questions are wrong. from the external examiner, they're actually wrong, because generally descriptive studies do not have hypothesis. But then what do they want? What do they want to see? For postgraduate students, often no external examiner will accept your study that you don't have any form of hypothesis. But why do they need hypothesis when it comes to descriptive studies? The idea of hypothesis in descriptive studies is making an extension out of the primary description. What do I mean by extension? For example, I'm the one that is assessing pregnancy-induced hypertension. Pregnancy-induced hypertension, that is what I'm assessing. Let's say prevalence of pregnancy-induced hypertension among women in Taraba State. Prevalence of pregnancy-induced hypertension among women in Taraba State. And this is a master's degree. So what am I expected to report? At the end of the study, I'm expected to say that on the total population of people I recruited, let's say the sample I recruited, so number have hypertension and so number have no hypertension. Therefore, the prevalence of hypertension proportionately is this %. When you finish that, you are actually done with the study. But can we accept that as a master's degree? Just telling us one singular thing. And after telling us that thing, you just say that you are done. The truth is that no any external examiner will accept that from you, because they will tell you there is no rigor. There is nothing demanding in that. And in fact, they will tell you that even an undergraduate student can do this. So for this reason, they now say that you need to have hypothesis. But what am I going to do with the hypothesis? What hypothesis am I going to come up with? Now, this is where you go. So, do you have, among pregnant women in Taraba State, do we have those that are career women? That is, they are working. And do you have those one that could be housewife and they are not going to work? Do you have those that are employed, those that are self-employed, and those that are non-employed? Do you actually have them? Is it possible to have this distribution? The answer is actually yes. We are likely going to have career, non-career. We are going to have employed, non-employed, self-employed. We are going to have this. Do we have those that are living in the rural area? Do we have those that are living in the urban area? Do we have those that have actually been nulliparous? And what do they call the other category? Sorry for women health, I can't remember, but multi-para, yes. So the thing is, do you have those that have given birth previously, those that have never given birth? Do you have them? Do you have those that are at the age of early, let's say 15, or let's say we want to go to the Nigerian Constitution, 18 to 25? Do you have those that are 26 and above? Do you even have those that are giving birth at late in their life? Let's say, for example, 45 and above. Do we have to the age of, let's say, 56 or 50 something before menopause? Do we have those such categories? Possibly we do. Now, can I create a hypothesis to say that there will be no significant difference, no age differences in terms of distribution of pregnancy-induced hypertension? Can I create a hypothesis to say that there will be no difference between women in the rural area and urban area in the distribution of pregnancy-induced hypertension? Can I create a hypothesis talking about differences between employed and non-employed? Or employment status will not affect the distribution of what do you call it? Pregnancy-induced hypertension, and on and on and on. You see, with these manipulations, I call them manipulation purposely because you've actually manipulated the age group, the state, the setting, the whatever. All these things that you put together has created a way for you to come up with different hypotheses. And for that reason, you should now come up with this hypothesis, and it gives you diverse way of looking at this distribution. It gives you diverse way of looking at how important this thing is. So coming up with such hypothesis enriches the study a lot. So does descriptive study actually have hypothesis? The answer is also yes, and the answer can equally be no. If we stop at the level of prevalence, we do not need hypothesis. If we stop, we expand it to the level of making comparison at different level or groupings, then we can have a number of hypotheses. And I hope this actually helps. That's the reason for coming up with this question, and I hope it helps us to understand more about descriptive studies. Any question about that? Or demand for clarity if it's not clear? Any question? Okay. I'm assuming that the explanation is clear and I can proceed now. Okay, I'm trying to share my slide so that we can continue from where we start. Just a minute, it will come on. Or is it visible already? No.
It's loading, sir.
Is it there?
Yes.
Okay, it's there, right? All right, systematic reviews. Now, when it comes to research, research is supposed to guide evidence. Research is supposed to guide evidence. What do we mean by guiding evidence? For it to tell us why we are doing what we are doing. What do you base your? Somebody is treating a patient using IR and for facial palsy, and you came and you now said, how can you be using IR for facial palsy? And he said, you see, I was trained like that. IR is so effective. And you have reason to say no. But how do you tell him it is no? You must rely on certain evidence. So such approach to tell somebody that this is what I rely on must be research-based. So in research, we have levels when it comes to evidence. From cross-sectional studies, descriptive studies, basically, to experimental studies, particularly when it comes to RCT, to what we call systematic reviews. Now, many people actually thought RCTs are better than systematic reviews in terms of level of evidence, and that is very erroneous. Systematic reviews are higher. In fact, they are called level 1 level of evidence. So they are a lot higher than RCTs when it comes to evidence. So we rely more on systematic reviews than we do for RCTs. So why do we do that? Because systematic reviews are a pool of different studies that are considered to be either effective or non-effective. For example, if we say the use of IR for facial palsy, like I said, and we have a number of RCTs being conducted to check the effectiveness of IR in the management of facial palsy. So systematic review, what it does is to pull different studies that are conducted from different parts of the world, from different regions, by different researchers, and confirm from those studies whether they all agree that IR is effective in the management of the facial palsy or not. And based on that, we will now, you can see that what systematic review is doing is it's pulling all the data from different parts of the world and trying to check methodologically, appraise those studies in terms of their standard, in terms of their methodological quality, and finally concluding whether we can accept that IR is effective in the management of facial palsy or not. So you can see, for the fact that it is not relying on one singular research conducted by either one or several researchers, it is considering all the researches that are available. You can see it's telling you how stronger it is over one single study. So systematic reviews are above RCTs when it comes to level of evidence. So that's the first thing I want you to know. So what is a systematic review? A review of the literature using explicitly stated search methods and criteria for evaluation of methodologic quality. So in systematic review, it is not like what you put in your literature review that I criticized earlier. It is about telling us from A to Z and how you are going to conduct the research. So the way you make description for methodology when it comes to conducting your other researches, that is how you are going to tell us step by step, methodologically, how you are going to conduct a systematic review. For example, you tell us what is the topic, so we know the topic. Secondly, you tell us how you are going to search, where you are going to search from, what are the places you want to check, what is the population of the subject you want to include in the papers, what population must they contain. You can see, imagine a review that is telling you population. Now, this literature is focusing on assessment of spasticity. So if it is spasticity that they, as a diagnostic tools for spasticity, that is what this is, my diagnostic tool for spasticity, then you now say a systematic review. So now, you can see that is a very wide topic, diagnostic tools for spasticity. Now, the problem is, diagnostic tools, since spasticity can happen in adults, it can happen in children, it can happen in stroke, it can happen in Parkinson's, it can happen in cerebral palsy and all that. You can see where I'm going to be getting my data is so wide. So what if my methodology is saying among adults with stroke? So I've defined that this study will be conducted in studies that examine assessment of spasticity in adults with stroke. You can see population has been defined. So any literature, any study that is conducted in other populations aside from the ones I mentioned will not be included in my literature search. So every stage of the research will be conducted. Now, do you know what is interesting? I can decide that only African studies will be included. Okay, only studies conducted on Black Africans will be included. So if a study is conducted in Caucasians or Black Americans or Hispanics, it is not going to be included in my literature search. And again, I can actually talk about the database. If I said among African databases available in Africa, in databases domesticated in Africa. So I've ruled out if a database is not in Africa, then I don't need that database. Can somebody mute the? Can we mute the individual interfering with us? Please mute yourself. Okay. Mr. Akande, we are sorry, you are disturbing us. Mr. Akande, can you mute yourself? Okay. All right. So what we are saying is that the literature search, everything that will make you to have a focus should be clearly stated in the methodology of your systematic review. So systematic review can progress to actually come up with data analysis. Imagine you are not the one that collected the data. You are not the one that collected the data. It's from different studies, but you can still pull the information from those studies and get data and analyze. In fact, what is interesting about this is that the population you are going to be having is the population from all the studies that you are pulling together. If a study has 20 subjects, another study has 120 subjects, another one have 500 subjects, another have 1,000 subjects. You are pulling all these this sample together to be able to analyze the data and now tell us what is your findings. The process that involves statistical analysis of summary of all the data that is available in all the studies that are being reviewed is what we call meta-analysis. So the difference between meta-analysis and systematic review is that systematic review stopped at appraisal of the information and interpreting findings. But when it is possible, so sometimes there are reasons why systematic review cannot progress to meta-analysis. And why wouldn't it progress to meta-analysis? There is what we call homogeneity and heterogeneity of information. What is homogeneity of information? If the information we are getting, I think we mentioned issue around spasticity. If the information we are getting from the data of A, data of B, C, D, E, they are looking at it for example, spasticity among adults is what was conducted across all the studies. Spasticity after stroke is what is conducted among all the studies. Spasticity, all the studies are domesticated in Africa and so on and so forth. Spasticity in male stroke survivors. You see, at the end of the day, let's say all these studies, what the subject, the title, the subject they look at, the setting, and so many things about all the studies, they are looking at it in similar way, as if they've spoken to each other. What data you are collecting and whatever they look similar. It's just the findings that are different. So when you have a significant similarity in the characteristic of data collected, then it is possible to proceed to meta-analysis following systematic review. But if at the end of this the data collection, we realize that there are no significant similarity in the data collected by different reviews or different different studies, then we cannot proceed with meta-analysis. That is to say, when the data or the information from different studies are essentially heterogeneous. So there is no room for us to proceed to meta-analysis. I hope this background helps. Okay. Systematic review design features. What are the features of a systematic review? Number one, there must be a focused clinical question. Assessment of spasticity among adults with stroke. You can see focused question. This is the thing you want to do. Explicit and thorough method for searching the literature. Now, when you want to search the literature, you must have a great systematic arrangement and content that is very, very explicit, so explicit enough, thorough enough to capture the information you are looking for. This is also a feature. Explicit and appropriate criteria for including and excluding studies in the review. So here is one very important thing. Just like you have inclusion and exclusion criteria for typical studies, whether cross-sectional or experimental studies, we also have criteria for including specific studies and excluding certain studies when it comes to systematic review. So you must be so clear that studies that have these characteristics, these features are going to be included, and studies that have A, B, C are going to be excluded. It must be also clear. All clinically important outcomes must be considered. So, what are the main outcomes that your study want to focus on? For example, the case that we mentioned about spasticity. Spasticity at what level? Is it the knee? Is it the wrist? Right? And again, the studies you are looking at, are they assessing spasticity or they are assessing improvement following the use of a particular intervention? So if it is the assessment of spasticity only they are focusing on, so you must be clear about the outcome you want to use. Assessment of spasticity, not improvement in the treatment of spasticity. These are two different things. Improvement in treatment of spasticity or assessment of severity of spasticity or the presence or absence of spasticity. So you must be clear about what is the clinical important outcomes that will be considered in the literature review. Subgroup considered when appropriate. So if there is need for us to have subgroups, then this should be also clear. For example, spasticity at early onset of stroke and chronic spasticity following stroke. So these are subgroups. At early stage of stroke, let's say acute stroke is one group and chronic stroke is another group. So you can see these are two different groups. You should be clear whether you want to have subgroups or you don't want to have subgroups. So that is about systematic review. We're not going to go beyond that because the class is for us to just talk about these things briefly. If you want us to have a special teaching, thorough A to Z of systematic review, you can intimate them at Ray, and by God's grace, we'll take you through the process of systematic review, including how to enter databases, how to download your article, how to interpret your article, and every stage that is involved in it, you'll surely be guided. So let us know if you are interested in training on systematic review. We'll be ready to actually take you through the process. Then the next thing is studies that are focusing on economic evaluations. A study that includes an assessment of the cost of alternative health care strategies. So a researcher could actually be working on what is interested in is the economic aspect of treatment. For example, a number of us have been treating stroke for ages, back pain for ages, osteoarthritis for ages, cerebral palsy for ages. But do you actually bother to know what does it cost to manage cerebral palsy in Nigeria? To date, there is no any document that says that universally the minimum a parent that has a child with CP will spend in managing the child in a year is this amount. There is no any study on that. Let's say such that the government actually has accepted that, yes, it costs parents this amount of money to manage a single case of CP in a year. For example, what is the cost of transport? What is the cost of medication? What is the cost of in fact, what is the cost of joblessness that this thing result in parent, and many more. So out of pocket expenses of parent, what is the out of pocket expenses of parent with a child with spasticity? So, and who are the right persons to actually do a research like this? Nobody is in the best position to do this aside from physiotherapists. After a doctor has given medication and whatever, what else is he going to do? What else? Does he have any other thing to add to the life of the patient? Literally nothing. So if he cannot add anything to the life of the patient, the maximum you can do is just to say, okay, go and see physiotherapist. Physiotherapist stays with patient for almost throughout their lives, depending on how the patient is improving. For a child with CP. So why don't you care about them? That all you care about is for them to come and you just do your PM and you ask them to go home. You can see frustration written all over their faces. Now, it is out of these kind of researches that researchers like you, physiotherapists, come up with something that will touch the heart of the government itself and say that if people are spending this much, what is the government going to do in terms of subsidizing treatment for patients of this category? Or can we say that every parent that actually has a child with CP should even stop paying anything? Nobody can bring such kind of a transformation in the life of the children and the life of their parent if not you, physiotherapist. But you never care about going to that extent. So how do you bring about, how do you even gain the respect? So if physiotherapists can change the life of children and their parent that have CP because of their own research and start shouting and publishing it in national dailies and even going to radio stations, television stations during, let's say, you want to have physio day of the year. And you now say all over Nigeria, the research that is conducted, this is what everybody should preach, should talk about in all the radios. And before you know it, activists and whatever will start saying, based on the research of the physiotherapists, let's mount pressure on the government. This thing has to change. Government has to come into their aid. The profession is going to gain a lot of image from researches like this. So how much do people with back pain spend? How much do people with stroke spend? What is the cost of managing facial palsy? So researches that are focused on economic evaluations, they are very, very important, and we should start looking into those areas of research as well. So comparison of well-defined alternative courses of action in terms of treatment, specified point of view, clinically important outcome must be considered valid evidence for the efficacy or accuracy of the alternatives you are suggesting, identification and valid measurement of all relevant costs should be done in such researches. Thank you very much. This is the end of this particular slide. We're going to go into more other aspect. So I'm going to take some few questions if you have them before we go into something else. So I'm listening to you. Everybody make your contribution, make your comments, ask questions. That's why we're here. We are not here to just talk about something without evaluating how much gain was people have made in this session. Please feel free to ask your questions. And if you want to make some few contributions, you are equally free to do that. This is why we are here. All right, I'm listening. You can send your question. You can ask question directly. You can unmute yourself and ask question. All these are allowed here.
Good afternoon, Dr. Isa.
Good afternoon.
Yeah, it was a very nice topic we are discussing, and I just want to say something about the last comment you made about making researches to push for, especially people with CP and what they go through, so that we can earn respect as physiotherapy and the profession.
Yes, sir.
So it's something that touched me and moved me. It's a very good thing to say, and I guess that is why we are all here, to learn something and then take something home.
Yes.
So
yes.
I'm urging, and I will help to preach that sermon around, so that we can all come together and do something, because actually people from, the parents especially, that come with their CP children, we see what they go through in terms of financial challenges. And this thing can be like, it's a journey, lifelong something, some of them throughout the whole life. And a lot of them even give up coming to the hospital because of financial challenges. So it's very, very important. I want all of us to take it very, as
Thank you very much, sir.
Yeah.
Thank you. For those who don't know, this is my big brother in school. So.
Thank you, sir.
Nice to hear from you, sir.
Yeah, nice to hear from you too.
Thank you, sir.
Yeah, good. Thank you.
Yeah, thank you, sir.
Yeah.
Okay, any other question, comments before we proceed to another wherever? I always like to have a feedback. I don't like talking without having a feedback. Sorry. My student in BUK also know me for that. Please make your feedback. Talk about whatever you want to talk about. Is going to help us a lot to improve. Okay, somebody say they are interested in the systematic review. Definitely, we're going to come up with it. Okay, somebody say we should throw more light on inclusion and exclusion criteria. Now, when we talk about inclusion and exclusion criteria, there are two ways actually. Is this inclusion criteria and exclusion criteria for systematic review or generally? Now, let me talk on general term, which may affect both systematic review and other researches. So when we say inclusion criteria, it means the basis for which something can be included in the study. If you are using subject, let's say patient, or other form of sample, even healthy adults, you must have specific things that will make them qualify to be part of your study. So those things that you consider that somebody must have this quality or this feature before that person will be included in your study is what we call inclusion criteria. But there is one thing about that. Exclusion criteria are not opposite of inclusion criteria. This is one of the major problems that students have. If I said individuals below the age of 18 are the ones, let's say children from the age of let's say 5 to maximum of 18 are going to be included in this study. I cannot say exclusion criteria, those that are above the age of 18. Why do I have to say that? Already I've excluded them by the inclusion. So I must look for something different that will make them ineligible to participate in the study, not what I said in the inclusion and now quickly interpret the exclusion. I mean, the opposite of it to mean my exclusion. That is not how inclusion and exclusion criteria are developed. Exclusion criteria are completely things that we actually look at that we cannot say, we can outrightly not be able to explain them in terms of inclusion, but they can never be included. Let's say, for example, I'm actually working on cardiovascular diseases in young adults. Let's say cardiovascular diseases in young adults. And my inclusion criteria are young adults with hypertension only. But remember, it is saying cardiovascular diseases, let's say hypertension, idiopathic hypertension, and hypertension from diabetes. So these are the things I want to check as, let's say, prevalence of these in young adults. But then how do I come up with my exclusion? My exclusion is that I'm not looking at consequences of hypertension. I'm not looking at consequences of hypertension. So don't expect consequences of hypertension in my study. My study is only looking at the hypertension itself from idiopathic or hypertension coming from diabetes. So even if somebody is included in my study as having hypertension, there is nothing concern me about the consequences, the problems associated with hypertension. So don't check for this in my study. So that is an exclusion. And many other ways of looking at it. So get to understand that exclusion criteria and inclusion criteria are two different things. They are not necessarily opposite of each other. So that is it for now. I hope we get to understand this. Now, please throw more light. Okay, I actually joined late. No question. Okay, so please, I know you talked about variable, but I'm a bit confused for quantitative. I don't think we've actually discussed variables that we only mentioned them partially. We're going to be talking about them, I think, in the next slide. We'll be looking at variables more closely, and then you'll be able to ask questions if you don't understand it at that time. Ms. Kate, thank you. So I think we can proceed to the next slide so that we move on from there. I'm coming. Just give me some few minutes. I need to quickly do something. Okay. I'm gonna share my slide now. So get ready for this one. All right. Is it visible? Is the slide visible, please?
Yes.
Okay. So this one is research methodology for clinical decision making, though we have another series coming. So this slide is going to be talking about variables, scales of measurement, hypothesis, and hypothesis testing. So pay as much attention as possible. What is a variable? A variable is described as a concept or abstract idea that exists in measurable terms. In clinical research, variables suggest all measurable characteristics, traits, attributes, or qualities of a given individual, object, or situation of interest to the researcher. Now, when you talk about variable, what they are trying to tell you is that anything that comes to your mind that is describable, that can be differentiated from another thing. For example, ugly, beautiful, fine, weak, strong. At least we can always say that an ugly face is different from a beautiful face. Being fine is different from being sick. So you can see there is a variation already there. So it's describing a variable. So to make it clear to most of my students, I said, what is in your mind that you feel is actually distinct from another one? And it has a partner that you can easily relate them. So if you can come up with anything that is relatable with another one and say that this one is like this and this one is the other way, then you have a good understanding of all those things you can think of. They are all variable. So variable can be abstractive and can be physical. So it's not all variable that can be seen physically. So you can see a variable physically, you can see it, you can think about it, you can assume it. Now, is a lady a variable? Is a guy a variable? Is a chair a variable? Is a house a variable? Is a street a variable? Is light variable? Is darkness variable? Is brightness variable? So when you keep looking at all these things, they've got name, they've got existence, so they are all termed as variables. So a number of times when you think about variable, you think like, if we can assume it, we can see it, we can think about it, then it's actually a variable. In clinical research, variables suggest all measurable characteristics. So anything that can be measured is a variable. Can we measure thinking? Yeah, we can quantify it. He thinks a lot. He doesn't think before he does things. Oh, she's black. No, she's white. No, he's English. He's Nigerian. So all those things that we can actually relate with, and we can measure their characteristics. Measurement does not actually quantification. Don't actually confuse quantification with measurement. Quantification is a measurement itself, but then if the mind can quantify it, is actually be measured. If the eyes can distinguish it, Distinguishing it is a measurement. If you can set and be able to identify difference between two things, you've actually measured them. So this is what we mean by variable. For example, age, gender, weight, height, percent body fat, pain, attitude, knowledge, cost of treatment, quality of life. Now, these are variables. Variables are not just measurable. They can as well be manipulated or controlled. So we do not just measure variables. We can actually manipulate them. That's to say, we can change them from one thing to the other. We can rate them, and we can control them. We can tell a variable not to proceed. We can tell a variable stay here and don't move forward. We can limit a variable to a particular place and don't allow it to go beyond that. And on and on and on. So let's go. What are the types of variables? Variables are into these descriptions: independent and dependent, extraneous and confounding, continuous and categorical. You are going to have other form of descriptions. You can hear they tell you that discrete variable and continuous variable. You're going to hear that from somewhere. Discrete and continuous variable. So you're going to hear different names, but these are the major classification of what we mean by variables. So let's look at them. Now, when we talk about dependent and independent variables, a number of times they could be confusing, but then it is easy for us to relate with them. What dependent variables are sometimes shortened to mean IVs, independent. Independent variables are sometimes shortened to mean IVs, independent variables, while the dependent variables can be referred to as DVs. So IVs acts as the cause or what makes something to happen because they precede, not proceed, they precede, influence, and predict the dependent variable. So the major work of the IVs is that they cause something to happen. They create a change. They ensure something different happen when they are in a place. When they are implemented, they cause something to happen. For example, sleep is a variable. Sleep is a variable. Now, a patient went to the hospital complaining about headache. And the doctor asked the patient, do you have a good sleep? Oh, these days my sleep is very poor. Okay, describe it. Oh, it's usually too short, and sometimes it takes me time before I go to bed. This is the description that is given by the patient. Then the doctor says, okay, I'm going to give you a medication. It's going to make you sleep. Now let's look at it. I'm going to give you a medication and it's going to make you sleep. So the patient took the medication and the patient is able to sleep. So what makes the patient sleep? It is clear that because the patient took the drug and the drug makes the patient sleep. So the cause of the sleep now is actually what? The medication. So being able to sleep is therefore dependent on what? The medication taken by the patient. So therefore, which one is independent? The medication is not dependent on the sleep, but sleep depends on the medication, because it's the medication that makes the patient sleep. I hope that is clear. Now, you have a situation like this. You wanted to take the blood pressure of, or let's say the pulse rate of an individual. And you ask the patient is lying in bed. Oh, let me change the example. You have a group of interns in your department, and you ask them to go to the ward and see some patients that are bedridden. So there is this patient known as Mr. Usman, and you have this intern, John. John went to the ward, took the BP, took the pulse rate of Mr. Usman, and he gave you a reading. And after coming up with the reading, it says 65 beats, right, per minute. So when he gave you this reading, and it is documented, so you were pleased with the whatever, you didn't have anything to say, you just feel that it's okay. And later in the evening, suppose this patient is a patient that needed to be seen, let's say, more than, let's say 3 times in a day because he's in the ICU. So they gave you 65 beats per minute in the morning. And all of a sudden, you ask the same John to go back to the ward and take the BP of this, take the respiratory rate or the pulse rate of this individual. And he came back with a reading that is around 79 beats per minute. That was a magnificent change.
I'm unable to hear you, sir. I don't know whether it's just from my side.
It's general. The fault is from the presenter.
Okay, thank you for your response, ma'am.
Amma abu na Google ko? Amma abu na Google.
ina ji kace saboda 11% din nan ne nace saboda 11% din nan ne ina so ce I lost wallahi sai na ci
Hello. Hello, everyone. Sorry, the facilitator had some technical issues. The network knocks him out and he's finding it difficult to rejoin. So he advised while we try to sort out the technical issues, can we take some 40-minute break to resume at 2 p.m.? Thank you.
Sorry, everyone. I had some internet issues since. I've been trying all along. I think we can proceed if you guys are ready. Can we proceed?
Yes, we can.
So we actually started discussing about variables, and I think sorry, give me a minute. Yes. So we started discussing about variables, and we'll continue from there. I think we've highlighted what are variables and the types of variables. So I progressed to start talking about what are independent variables. So I was trying to give an example about an independent variable. Now let's assume you actually have an intern, and this intern was sent to the ICU to assess a patient for, let's say, the pulse rate of the patient, heart rate of the patient. And when this intern got there, he went there in the morning, and the heart rate was indicating 65 beats per minute. So he took the record and came back to you in the department and showed you the record. Assuming this patient is supposed to be reviewed 3 times daily for the heart rate. So in the afternoon, the intern was asked to go back to the patient, and on his return, he came back with a different heart rate, and this heart rate is indicating 79 beats per minute. So you were like, how can it happen? Why the significant variation? Okay, let me just see what is going to happen. So the intern went back around, let's say before you close from work, which is, let's say, roughly around 3:30 to 4. And he came back with a different reading, and this reading is about 90 beats per minute. So this caused a worry to you, and you decided to say, I'm not sure you are actually getting this right. Probably you have problem with measuring heart rate. So you went with the intern to the ICU, and you are actually complaining about what the intern brought to you. Then a nurse confirmed to you, nurse intensivist actually confirmed to you that he actually took it correctly. She saw it when he was checking it, and there was nothing wrong. So why the variation? So you decided to take the beats by yourself, the heart rate by yourself, and you found roughly 66 beats per minute. Now the question is, why are you having this variation? Now you decided to find out from the intern. Oh, tell me about the position of the patient when you were trying to take the heart rate. He said, oh, actually when I came in the morning, he was lying down, so I took it. And when I came in the afternoon, he was sitting down. And when I came in the evening, he was trying to take a walk, so he was standing when I took the heart rate. Now, oh, no wonder you got different reading. So that is actually suggesting something is happening. And what is it? That the posture of the patient can actually influence the heart rate. Now, going by this example, it is clear that when the posture of a patient is manipulated, is actually changed, then it is very likely that that could actually affect the heart rate of the patient. So in this example, it is clear that the posture, it is an independent variable, right? The posture is an independent variable, while the heart rate depends on the posture of the patient. So now what did we manipulate? We manipulated posture. That is to say, we changed the position of the patient. Similarly, in general, when you want to define independent variable, it is that particular variable that when changed, when altered, will bring a change in the dependent variable. So let's move a little forward. We get to understand it more. DVs, on the other hand, are products or effects that manifest or occur as a result of manipulation of the IV. So the manipulation or the changing or the alteration of the IV brings about the DV. They are also known as outcome variables. So they are the ones that are produced following the manipulation of the IVs. So let's look at this trial question. A final year physiotherapy student was concerned that recovery is faster in adhesive capsulitis in some patients than others following physiotherapy. So he's concerned that recovery is faster in adhesive capsulitis in some patients than others following physiotherapy. He contemplates on what could be the reason. He therefore assumes two reasons may be responsible, including number one reason, some patients receive more repetitive physiotherapy sessions, and some patients have great chances of recovery spontaneously. So, two reasons. Number one, patient could recover because they receive exposure to physiotherapy more repetitively than others. Then some patients have natural chances of recovering faster. He therefore set out to investigate the effect of repetitive physiotherapy and spontaneous recovery of recovery of the patient. In the above study, what are the IVs? The two IVs there is that it's either recovery will actually depend on whether physiotherapy is done repeatedly, or it is a natural process that brings about recovery. So these are the two IVs. Recovery of patient may depend on spontaneous recovery, or it may depend on repetition of physiotherapy. So that's an IV, and the main DV there is recovery of the patient. I hope we're together. Okay. Let's see. Sorry. Yeah. So some research situations do not lend themselves to the use of these two terms, independent or dependent variables. Such studies are not formulated to investigate cause and effect. So we have studies that you do not have dependent and independent variable. For example, somebody who is trying to see the prevalence of something, you definitely don't need any independent variable. You don't need any dependent variable. You just have a variable to investigate, which is just the prevalence of that particular condition. So this should be clear to people that it is not every research that have dependent and independent variables. Typically, a study examining relationship between two variables such as attitude and success. The question is whether good attitude correlates with success, or high level success correlates with good attitude. So this is examining relationship, but it's not examining cause and effect. We cannot say good attitude is what causes success. We can only say it relates with success. So there is no cause and effect in that situation. The other example is a clinician may as well be interested in knowing whether amount of repetitive task training correlates or causes greater neuroplastic change. So in this case, you have a cause and effect. So it is not the case of correlation. he may decide to investigate whether high amount of repetition task training causes greater neuroplastic change, or simply does change suggest higher amount of repetition. Now, the main thing is repetitive changes may bring about, a repetitive practice may bring about a gain in neuroplastic change, not a correlation in this regard. So let's look at two different other sets of variables. This time we're talking about extraneous and confounding variables. A great number of times, one thing about these two variables is that they look so much alike that to a very large extent they are used interchangeably. They are considered to be synonymous. So when they say extra, which means addition, something is not is out of the primary. It's out of the primary, so it's an extra one. So extraneous means something that is not within, it is from outside. So extraneous variables are variables that could affect outcome variables in a research when they are poorly controlled by the researcher. So if the researcher did not control for extraneous variable, they could actually influence the research. Okay, let's go. Typically, a researcher who intends to investigate the rate at which patients abscond treatment in chronic disease conditions may need to control for treatment in chronic, may need to control for socioeconomic status of his participant. Let's look at that example again. We say a researcher who intends to investigate the rate at which patients abscond treatment in chronic disease condition may need to control for economic status of his participant. Age, proximity to study setting, and availability of caregivers. So what are we trying to say? You're trying to see why are patients absconding treatment. Now, what if it's because they don't have, some people are actually absconding because they do not have enough money to transport themselves to the hospital. So you see, if you want to say, you want to investigate something like this, you may actually need to say that people of nearly equal socioeconomic status are going to be investigated, which means you've actually controlled for the influence of socioeconomic status in determining rate of abscondment from treatment. So if you did not control for socioeconomic status and you are giving us a report and people are of different socioeconomic status, the result may be erroneous only because of the variation in socioeconomic status. So therefore, holding the socioeconomic status tight to ensure that the participants in your study are of nearly equal socioeconomic status would be good to give us a better outcome than when there is variation in socioeconomic status. What about age? The chances of people absconding treatment probably may be related to age. And when we talk about age here, somebody may be thinking that, I think older adults, that is the geriatric population, may abscond treatment more than the younger adults. Somebody may think like that, but that may not necessarily be the case. Probably because they have more caregivers are taking care of them, probably they will attend. What if the younger age are the ones that abscond treatment more than they whatever? Because at younger age, you are more active. And therefore, you needed money to support yourself, you needed money to support your family. So the chances of you getting to abscond treatment may be higher than somebody who is not in that category. Please, if I can make this announcement, please, if you have contact of some of the participants, I realize our number has decreased because of the problem I had in coming back. Some people may still want to join because they wouldn't know whether we are back or not. If you have a way of contacting them, please do. So let me proceed. So like I'm saying, typically a researcher who intends to investigate the rate at which patients abscond treatment, one of it is age. What of proximity to study setting? Those who are closer may actually be coming to the hospital more than those that are not closer to the hospital. So you can see proximity could be a reason. So what of people who actually have caregivers and those who do not? If you have caregivers, probably they may motivate you to come to the hospital compared to those who do not. What of the social support and all that? There could be many other factors that may actually affect this study. So those extra factors that may affect the study outcome, they are what we refer to as extraneous variables. So not controlling for these variables may affect the study findings. So that's about extraneous variables. What of confounding variables? Let's quickly say something about confounding variables. Confounding variable influences the dependent variable and also correlates with or causally affect the independent variable. So confounding variables are majorly going to influence the dependent variable, while the extraneous variable can affect both. Confounding variable focuses or largely affect the independent variable. So when, to a large extent, they are looking alike, but confounders, their major impact is on dependent variables. Let's take, for example, if we say blood pressure. Now, what are the likely things that could affect blood pressure? What could affect blood pressure could be systemic, blood pressure could be systemically affected and could be extraneously affected. Now, if what is impacting, let's say, for example, the intensity of exercise that people are exposed to is different. Let's say we have, okay, let's look at age, for example. Let's look at age. Now, age as a primary factor can actually influence your blood pressure. So if we look at age, it could affect the blood pressure directly, not indirectly. So for the fact that it can influence the blood pressure directly, it is actually a confounding variable. So if we are selecting subject and what we want to check is actually the dependent variable we want to work on is blood pressure. Since we know primarily age is a factor that can affect the blood pressure, so in selecting subject to participate in our study, we should ensure that a primary factor that can affect the dependent variable should be controlled. So now, if I am going to expose people to an exercise and I want to see the impact of the exercise, then I should control for age. I should make sure that the people that are going to participate in the study are of similar age group, so that age will not be a factor that is causing the change I'm seeing. I hope this is clear. So, but all other things may not. Now, for example, if we say socioeconomic status, socioeconomic status is not a primary confounder of, what do you call it, of blood pressure. It is not primarily going to affect the study. So therefore, it's not a confounding variable, but it could be an extraneous variable. Something like that. I hope this helps. Why a researcher may encounter extraneous or confounding variable? Why are you going to encounter that? So this individual participant differences in individuals could actually cause you either extraneous variable or can push you to having a confounding variable. Non-standardized instruction. If the instruction you are giving to your participant is not standardized, then you are likely going to have a confounding or extraneous variable. I gave you an example earlier about using a questionnaire with issues of translation. So if I'm administering questionnaire and the means of communication with patients is different, so the likelihood of people understanding that questionnaire differently may actually affect my study causing me extraneous variable. Order effect. So when they talk about order effect, this one I may need to explain. Please focus and pay attention to this one. We're talking about order effect. Now remember, when we are discussing about study design, particularly under experimental studies, where we say we have two experimental study, we have quasi-experimental, then we say single sample design. So in single sample design, that's where we have a lot of issues related to order effect. Let me give you an example. Suppose we're trying to see which of the following is more effective way of convincing people to participate in an exercise. Which of the following ways is more convincing in trying to make people to appreciate or participate in an exercise? So, number one way is advertisement. And we say advertisement in this regard is for us to now show a lot of jingles. For example, we show a woman who was very fat, and she started exercising and her body changes. She becomes a little slimmer and more attractive. So that's an advertisement. And the other one is face-to-face interaction. So we have face-to-face interaction and what? And advertisement in a way of trying to convince people to participate in an exercise. So a researcher actually said, I think face-to-face is better. Then another one said, no, I think advertisement is better. So you now have two groups of subjects, though we are trying to explain order effect. So the first group were actually interactive. So you have two groups of subjects. Group one, they are going to be interacting with somebody who is going to talk to them directly, face-to-face, and convince them that they should participate in exercise. Then the other group were going to be exposed to advertisement. So each one of them was asked to go ahead. So at the end of the study, we are making comparison how many people were convinced on face-to-face and how many people were convinced on advertisement. So after the entire thing, we concluded that advertisement is better. Somebody now said, I don't think so. So we now say, okay, let's have a switch. Those who receive advertisement should now receive face-to-face. And those who receive face-to-face should now not face-to-face. Oh, think face-to-face is now better, not advertisement. So they're clearly exposed to advertisement. So when they were initially exposed to advertisement, so they tend to like participate. But later, when they now receive face-to-face, the participation becomes better. So we could be concluding that is the face-to-face that is better, not the advertisement. So forgetting that it is actually going to lead us to something they call learning effect. Learning effect. Because now initially they receive one information. So there is reinforcement by bringing in face-to-face. So the reason why participation has increased is because there is reinforcement from the side of the face-to-face. Not really because face-to-face is better. So researchers now say that the order at which patients are exposed to a particular thing may influence how they respond to it. So that response, that ordering could actually have could become an extraneous variable. What of placebo effect? There are situations where you are assuming that the intervention you are giving a patient is actually the reason why patient is improving. Unfortunately for you, it is not because of it. How do we know about this? Patients just appreciate the fact that, for example, people who do PP a lot, you know it, that sometimes you take your mobile infrared machine, you go along with it. But deeply inside your mind, you know that that IR is not doing anything to the patient. Or sometimes you just apply things, not really because you are expecting things to do anything, but you want the patient to feel that you are doing something. But you know that the either the IR or the things, none of them is actually doing anything. What is working for you, which you know, is actually the exercise or the manipulation you are giving the patient. But you decided to add this because the patient will be more convinced that something has been done. And the fact that you have this machine and that machine, many patients are appreciating the fact that you are actually doing something wonderful. But deeply inside you, you know those machines are not the ones that are doing the work. So what is it then? It is a placebo effect. There is this consistent belief that if A is applied, there should be expectation of change. It's just like what happened in the north, which I don't know whether it's happening down south. When you ask a patient, we are going for physiotherapy, they will say yes. Oh, so you receive physiotherapy? Yes. But they may not actually agree that they receive physiotherapy until when they are exposed to heat. And that is why they are calling it gashi. So if there is no gashi, there is no treatment. That is, if there is no heat added, then they did not receive physiotherapy. So you see, this is the point we are trying to make. If heat is now added, the field treatment has been done. So is the heat producing the effect, or you are just adding the heat to just convince the patient that something has been done? So this is an aspect that all of us should understand, that there is an aspect of your treatment that primarily you know it is not playing any effect. So that is what we call placebo effect. Nothing, the treatment itself is not the major thing. It is the psyche of the patient that have a feeling that something has been done, and for this reason, they believe that the change they are experiencing is because of what is done. But primarily what brings the change is the placebo or psychological effect. I hope this helps as well. What of the experimental effect? Now, experimental effect here, sometimes we have what we call the fact that when you expose patient to treatment, they truly believe it's a treatment that works. So if the treatment works, that is the experimental effect. So you could have an effect. So the experimental effect in this case, sometimes you could have it as a reason why you have extraneous variable. And experimental effect, we are not talking about the experiment itself. We are talking about the researcher. The researcher being the cause of the extraneous variable. For example, I've mentioned a number of times that you are not expected to be the one that is going to take the outcome of your study in terms of assessment, where we say blinding that I mentioned several times. So when you now have a situation where the researcher himself, he knew the group he is putting in the experiment group, and he knew the people he's putting in the control group. In the first place, the people he recruited and he quickly put in the experiment group, they are a lot better than the people that are in the control group. So the chances of people recovering in that side where there is intervention is higher than the situation where the control is. So, and he is claiming that the reason why my patients are improving is because of the experiment. So experimenter, which is the researcher in this case, could actually be the cause of extraneous variable. So we go to the next one. Here we're talking about discrete, continuous, and categorical variable. So in discrete variable, let's start. Continuous variables can have any value in range between minimum and maximum. A continuous value can have an upper and lower bound, but it can assume or take any value in range. So when we say taking value in range, it means any form of a value can be termed as what? A continuous variable. For example, 2.2, 2.1, 2.5, 5.5. These are different values. And any variable that can appear in this format is a continuous variable. For example, what is your weight? I am 52.2 kg. I am so kg. What is your height? I'm so meter. Point this, point that, point this, point that. So these variable of these characteristics that can exist in any form, that can take decimals, that can be halved and still be considered as a variable, they are known as continuous variable. They are known as continuous variable. But what of categorical variable? A categorical variable are descriptive and not numerical. They are not numerical. So continuous variable are generally numerical, while categorical are not numerical. So they are basically descriptive. So any way to describe something is a categorical variable. Hair color, the type of hair color is actually a category, whether black hair or white hair or gray hair or whatever hair you call it, it is actually categories of hair. Gum flavor, dog breed, the type of breed, skin color, race, cloud type are all categorical variables. Party system, like PDP, APC, whatever, they are all categorical variables. So categories of people in APC, categories of people in PDP, Labour Party, and all that, those are all categorical. There are two types of categorical variable. Number one is what we call nominal categorical variables. Are not ordered. They are not in ordering form. So nominal categorical variable are things like I say APC, PDP, whatever. So they are represented by their names. So male, female, they are all nominal categorical variable. The order doesn't matter. So there is no way, yes, no, yes and no. Is the lady beautiful? Yes. No. Okay, because I say no, am I less than the person who say yes? No. The clear thing is that I decided to align myself with those who say it is yes. And you decided to align yourself with those who say it is no. So there is no difference between either no or yes. They are equal in terms of choice. Is my choice to say yes, is your choice to say no. So they are just, we nominated, I nominated yes, you nominated no. I stand with yes, you stand with no. So this is it. So all categories, all variable of this form are known as nominal categorical variable because there is no higher or lower eye color. There isn't a reason one is first or last. So they are the same. What of ordinal categorical variable? In ordinal, do have order. They actually have order. And that order cannot be violated. Educational level. So now if you are in 100 level, are you equal to somebody who is at 500 level or 600 level physiotherapy class? No. That is your level. And that is where you belong. So the next level is 2. What of the rank of soldiers? What of the rank of police? What of your rank in your office as physiotherapists, senior lecturers, senior physiotherapists, whatever. What of in academics we have lecturer 2, graduate assistant, assistant lecturer, lecturer 1, and so on. These divisions, this hierarchical arrangement, this hierarchical arrangement is an order. So that order is also a category. Categories of nurses that are nursing officer 1. Categories of physiotherapists that are senior physiotherapists. Categories of directors of physiotherapy. So these are the things, and I believe so it is also a categorical variable, but then in an orderly manner. There is an order. There is a chronologic arrangement. Note that there is not some exact difference between the levels of education, just that they can be put in order. So sometimes there could be difference in the level of education, but they can be put in order. And sometimes it is just for us to have an order. It is, but when you are in level 1 physiotherapy and level 2 physiotherapy, all of you are physiotherapy students. Both of you are physiotherapy students. So it doesn't necessarily mean that you are no more physiotherapy student when you are in level 1, and therefore when you are in level 5, you are more physiotherapy student than the other one. You are both physiotherapy student. The only thing is just that there is need for that ordering. What of a discrete variable? A discrete variable only allows a particular set of values. Remember, in continuous variable, we say it takes all values. But in discrete variable, it only allows a particular set of values. And in between values are not included. In between values, there are no values in between. It's either all or none. If we are counting a number of things, for example, number of chairs. If we say number of chairs, we cannot have 21.5 number of chairs. It either they are 20 chairs or 21 chairs. You cannot have 20.5 chairs, 20 and a half chairs. They are all either all of them are chairs or not. That is a discrete value. A dice roll has a certain number of outcomes. It's either the dice is 1, is 2, is 3, and whatever, or is 4, is 5. You cannot have 4.6 dice. You cannot have it. It's either it's 4 or it's 5. So let's go to a different thing. We are moving away from variables. Probably if you have 1 or 2 questions on variables, if there is anything that is not clear, I will quickly explain that before we move into scales of measurement. Any question about variables? If you quickly have either dependent, categorical variables, or whatever, independent variable, if there is anything that is not clear, please quickly send the question. Or if you want to talk directly, you unmute yourself and say, ask your question before I move on. I think there is Miss Ruben who asked me a question earlier. I hope with this explanation, it is clearer now. Any question for me? Just 1 minute. I'm going to give that for only 1 minute. When it is 2:50, I will continue with my lecture if there is no any question. Okay. You unmute yourself, please. You can unmute yourself. I'm not in control. The admin is Dr. Samani. Try to unmute yourself.
I think there is no restriction. The person can unmute and speak. No restriction.
Unmute yourself. You are not muted. Miss Kate, you can unmute yourself and talk. Otherwise, you have to type in if you cannot unmute yourself. Okay, you can send in your question. I said I'm going to continue after 50, when it is 2:50, so I'm going to proceed. Oh, sorry about that. If you can send in the question, it's okay. Otherwise, you keep trying to unmute. Anytime you unmute, you are able to unmute. You can say, "Excuse me," I will allow you to talk. Okay. Let's proceed. Okay. Now we are into scales of measurement. There is this man that decided to create trouble for us, Mr. Stanley Smith Stevens. So they call it Stevens scales of measurement. He's a psychologist, and he developed these scales of measurement. These scales of measurement are very, very helpful. It's as old as 1946. Only some big guys among you. Me, I wasn't born. Some of you are probably born by 1946. So elders, you are welcome. So theories of scales of measurement. He suggested that all measurement in science was conducted using 4 different types of numerical scales, and he called them nominal, ordinal, interval, and ratio. We're going to be looking at each one of them now. So let's go into the business. Okay. I don't know if I'm right. Okay. So we go into nominal. The word nominal is like to nominate or to name. So anything that indicates naming is an indication of a nominal variable, provided it stands as a name and does not give any other meaning aside from being a name. It is a nominal variable. For example, when I say, what is your name? And you say, my name is Kate, my name is John, my name is Mahmoud, my name is Isa, and so on and so forth. These are nominal identifications. So generally, nominal variables are for identification. They do not add any other thing aside from being source of identification. There is nothing they add aside from being source of identification. I'll pose to just respond to this question. In the above topic, what are the variables? What is the rate of utilization of patterns and level of awareness of musculoskeletal physiotherapy in a particular hospital? So what is the rate of utilization of patterns and level of awareness? Now, the main the main variable here is actually the awareness. Now, when you decide to say you want to see the patterns of awareness or the level of awareness, the primary, variable is actually awareness of musculoskeletal physiotherapy. Now, patterns could be categories of it, levels could be categories of the same thing. The primary variable there is actually awareness of musculoskeletal physiotherapy. Now it's left to you to now say the categories of awareness or the patterns of awareness. So the primary thing there is the awareness. Now it is you that decide that you want to see the patterns. The patterns are categorical variables. The levels are equally categorical variables. I hope that takes care of your, that answers the question. Okay, talking about nominal. You can see the example we give we say political parties, name of persons, marital status, whether married or single, occupation of people is nominal. I'm a physiotherapist, I'm this, I'm that. Employment status is also that. Race is also that. Ethnicity is also a nominal thing. Biological sex, whether male or female, they are all nominal variables. So this is a categorical scale with mutual exclusivity. When we talk about mutual exclusivity, we are referring to the fact that when you are known as so-so-so, when so is your identity, you cannot have a for example, you are a male. You cannot be a male female. It's either you are male or you are a female. Thank God, even those that decided to create something confusion for themselves to say there is something known as transgender. After becoming a trans, you still have to identify with one. So if you decide to yourself from a female to a male, it is you that you now know more if you're going to acknowledge or identify with one thing. So what you identify yourself with is your nominal status. So, and you cannot be A and be B at the same time. You can only be one of them. It is the least precise of all the four scales of measurement. So it is not very precise. When it is mentioned, it is just specifically for identification. It is also called naming. You see that? It is known as naming. There are more mere codes assigned to objects or labels. They are simply symbolic identification, not a real measurement. So there is nothing you are quantifying when it comes to nominal variable. So it's just symbolic identification. They are not measures of quantity or size. So they do not measure quantity, neither do they measure size of something. Numerical figures can be used to designate category, but the numbers do not represent quantitative measurement or measures. So we can designate category with them, but the numbers do not actually indicate measurement. For example, I talked about issue of somebody who said, the lady there, is she beautiful or is she ugly? And you say yes. And somebody else say actually no. But you want to know the number of people who say yes. So you now say every yes should be represented as 1. And every no should be represented as 2. So being 1 or being 2, that 2 is not greater than the 1. It's just an identification. So it's a coding that is representing either yes or representing no. So the 1, either when it is 1, the 1 is just an identification. The 2 is equally an identification. 2 is not greater than 1 in case of coding, and particularly for nominal variables. I hope we've been able to explain this in a more clearer term. Okay. So let's look at this order of sophistication of measurement. Now, when we say sophistication of measurement, that is to say, how powerful is one over the other? Nominal variable, they are category names. So they don't have meaningful order. They don't have equal distance. They do not have true zero and ratios. They do not have that. But what of ordinal measurement? In ordinal, it gives you names, then it gives you order. For example, tall, taller, tallest. So a tall person is identified as tall. A taller person is identified as taller person. That's the category he belongs. The tallest person is identified as tallest. That is the category he belongs. But again, in terms of arrangement, we know taller is greater than tall. We know tallest is greater than taller. So in a way, we have ordering in the representation. But what of interval? In the case of interval, it's also more sophisticated than ordinal. First, we know ordinal is more sophisticated than nominal. Now, interval is more sophisticated than ordinal. How? Because the fact that we say, what is the time? It is 2 p.m. So we've identified the period by name as being 2 p.m. So is there a meaningful order? Yes. Meaning 2 p.m. is greater than 1 p.m. So there is a meaningful order. Okay, is there an equal distance? Yes, there is an equal distance. How? Because the distance between 1 p.m. and 2 p.m. is the same thing as the distance between 2 p.m. and 3 p.m. So there is an equal distance in terms of when we make our categories, there is equal distance. In the case of ordinal, toll, toller, we don't know what is the difference between the toll and the toller. There is no equal distance. Nobody made that measurement. But in the case of interval, there is measurement of that what do you call it? Of that interval, and the distance between them is actually consistently equal. What of true zero? Or true zero? There is no true zero in interval ratio, in interval scale. Wow, how? Because since we are using time to make our explanation, when we say 2 p.m., 1 p.m., 3 p.m., they have equal distance. But do we have 0 p.m.? Or do we have 0 time? Yes, we do have 0 time. What is 0 time? 0 time is 12 a.m. In 12 a.m., does it mean that 12 a.m., when we reach 12 a.m., there is no time again? No, there is time, but the time is a reverse one. It's not the one we know. So 0, by being in 12 a.m., does not mean we are completely, no time is existing. Time is still just that it is existing in a reverse. So that we say there is a 0 time, nobody is continuing to circulate as a clock. What of ratio? In the case of ratio, when we say the weight of the lady is 50 kg, so we have identified we've been having on and off. I hope you did not miss a lot in terms of explanation. So I've explained ratio scale. I've explained ratio scale. I've explained the nominal scale as well. I don't think my slide is, can you see my slide? Is my slide shared?
No, sir, we can't see your slide.
Okay, let me bring it back. It's because the network has been fluctuating a lot. It will soon be there. Okay, I guess it is there now, right?
It's back.
Yes, sir, we can see now.
Yes. So I've explained what is nominal, I've explained what is ordinal, I've explained what is interval, and I think people, did I explain ratio? Did I explain ratio?
You were still explaining ratio.
Okay, I was explaining it when it went off, right? Okay, so like I said, when somebody say my weight is 50 kg, that person has been named as a 50 kg person, which means it has that naming, it has that description met categorical representation in terms of names. Now, order, is 50 kg and 60 kg the same? No, 60 kg is greater than 50 kg, so yeah, it has followed order as well. What of equal distance? The distance between 50 kg and 60 kg is equal to the distance between 60 kg and 70 kg. So equal distance is also maintained. What of true zero? Absolute absence of that particular measurement. If we say there is a 0 kg, which means that thing does not exist. If we say there is a 0 height, which means that thing does not exist. So whenever a variable, if 0 means that that thing does not exist, the measurement scale for that particular variable is a ratio. The measuring scale for that particular variable is a ratio measurement. I hope that is clear. For example, waist circumference. Is waist circumference, when we say somebody have 0 waist circumference, is it possible? It's actually not possible. So which means 0 waist circumference means that there is no waist circumference, which means there is no human being with that. So since there is no 0 waist circumference, then waist circumference can only be measured using ratio scale. I hope that is clear. For example, let's look at interval. When we say 0 degrees centigrade of temperature, 0 degrees centigrade of temperature, does it exist? Yes, it does. That means it is already in a frozen state. So we also have -0 degrees, -0 temperature. So temperature is an interval variable. It can never be a ratio variable because 0 does not mean absence of that measurement. I hope this is clear. So how do we statistical measurement for nominal scale? If we want to assess, we want to use statistics to analyze a nominal scale. For example, the variable you are collecting is actually a variable that is nominal. For example, party system. So if we want to use statistics to bring out results for a data collected and the data is of nominal characteristics, for example, the party system, for example, the gender, male and female. So what type of statistics can help us to bring out meaning for a nominal data? So statistics, frequency distribution, and mode. These are the major type of statistics we can use. Frequency distribution and mode. Median and percentiles cannot be used. Add or subtract cannot be used. Mean, standard deviation, standard error of mean cannot be used. We cannot use them. Ratio or coefficient of variation cannot be used. But chi-square, we can actually use chi-square. So the what do you call it? The inferential statistic for a nominal variable is chi-square. So some of you may not necessarily understand this one because this is a research class. We are only trying to guide you. So when next you have a situation, you are doing a research, you already know that these things are not applicable for nominal scale. And you now know what is applicable for nominal scale. So when you take it to a statistician to help you in analysis, if he is telling you that he's doing 1 standard deviation, whatever, you know he's just lying. He can only give you frequency and mode and can equally do chi-square. So we go to ordinal scale, which I think I've explained earlier, and I may not necessarily need to waste too much time on it. The scale allows the researcher to rank performance of items in the same category, but the exact unit of measurement is unknown. Typically, Ummi is faster than Aisha in typing, but the actual duration or time is not known. So Ummi is faster than Aisha in typing. So we only say both of them are typing. Aisha can type, Ummi can type, but Ummi is faster than Aisha. So that is an order. Fast, faster. It designates ordering like A is taller than B. Does not define the distance between consecutive figures. There is no one that can say how faster is Ummi over Aisha. Since it is not a continuous variable, so typically we can only say fast and faster, but we don't know the distance between Aisha and Ummi. It is more precise than nominal. Of course, it's better than nominal because at least we know the order. Both of them are typing. Who is faster? We can say. Example of these are student performance in class. For example, when we say, for example, in a mathematics class, somebody scored A, somebody scored B, somebody scored C. We don't know the distance between A and it's actually very possible that the person who scored A actually only had 0.01 higher than the person who scored B. And the distance between the person who scored B and the person who scored C could actually be up to 10. The only thing is just that this one is B, this one is A, based on the fact that this one has more score than the other. But what is the distance between A and B, B and C? We do not know. Muscle power that you usually calculate in the clinic, it is actually an ordinal scale. When you rank 0, 1, 2, 3, 4, 5. Severity of pain, ranking of osteoarthritis, Likert scale, all these are ordinal scales. What are the statistics for ordinal scale? We can use frequency, we can use median and percentiles, add or subtract, we cannot, mean standard deviation, standard error cannot be assessed for an ordinal scale, ratio or coefficient of variation cannot be used, parametric statistics cannot be used, non-parametric statistics can be used for ordinal scale. Interval, it is more sophisticated and refined than both nominal and ordinal. It designates equal ordering or equal interval ordering in measurement. 0 does not represent absolute absence of measurement. So when we say 0, there is still measurement. A typical example is temperature, clock, IQ, age. So all these are considered as interval scales. So we move to the statistic for it. We can do frequency, we can do median and percentile, we can add or subtract, we can do mean, standard deviation, standard error, we can do ratio of coefficient of variation, we can do parametric statistic, we can do non-parametric statistics. Is not always, but sometimes we may go, particularly when data is not normally distributed, we are going to go for non-parametric statistics in this particular situation. The ratio scale, this is the most sophisticated and refined scale of measurement compared to the 3 above. It has absolute 0 points, suggesting total absence of a given attribute. If 0 is mentioned, that thing does not exist. It clearly defines magnitude of difference between two individual items or intervals in same group. So typical examples are weight, height, distance between two points, size of an office, waist circumference. All these are ratio scales. What of statistics? Statistics, we can use frequency, mean and percentiles, add or subtract, mean standard deviation, ratio or coefficient of variation, parametric statistics, and non-parametric statistics. All of them can be used straight ahead. So we go to hypothesis testing. So before we go into that, I would like to take some few questions if you have some questions for me. please type your questions or just indicate that you want to talk, then I allow you to talk. Sure, indicate your interest. If you have some quick question, please. Let me attend to your questions, then we move forward. Any question for me? You can unmute yourself if you want to talk and just say your question straight. I'm given 2 minutes before I proceed. One more minute. If there are no questions, we are going to push forward. Okay, I think I'm going to proceed. You can drop your questions if there is any. If there is any question, you drop it later. We'll attend to it. Now we go to hypothesis. One key thing that is very important in research, particularly when we say the research is an experimental form of research, and even if it is not experimental, you remember, provided you can construct hypotheses, then there is need for you to test the hypothesis. Earlier in the morning, we talked about descriptive studies having hypotheses. And I gave you reasons why we can have hypotheses in descriptive studies. And I said it's focused on robustness and increasing the rigor of a study, particularly for postgraduate students, where expectation is very high. So hypotheses are hugely of two types: research and statistical hypotheses. So we'll be looking at them. The hypothesis provides the justification for the clinical trial. It is antecedent to the trial and establishes the trial's direction. So what the hypothesis does is to show you the direction of the study. Hypothesis testing is the most widely employed method of determining whether the outcome of a clinical trial is positive or negative. So in the course of trying to assess whether the outcome you have is actually negative or positive, that is where hypothesis plays its role. Hypothesis testing is the key to our scientific inquiry. It guides to our questioning in science. Hypothesis testing does that. In addition to research hypothesis, we need statistical hypothesis. It involves the statement of a null hypothesis, an alternative hypothesis, and the selection of a level of significance. So essentially, when it comes to research, we talk about research hypothesis and what we call alternative hypothesis. So there is the statement of null hypothesis is a statement that often say does not happen, no, and always question the possibility of something happening. That is what null hypothesis does to you. Is I need a 5-minute break. Just 5-minute break. Give me like 5 minutes. Don't go offline, please. It's just 5 minutes. Okay, guys, I'm back. Can we proceed? All right, guys, I'm back. So hypothesis testing, we say it is the key to our scientific inquiry. So when we make assumptions and we state hypotheses, we are challenging the possibility of our intervention. So, and that's why we come up with hypothesis. So when I said we have research hypothesis, we have alternative, and we have statistical hypothesis. So in research, essentially, we go for statistical hypothesis. And the statistical hypotheses are majorly the null hypothesis. And it involves the null hypothesis, an alternative hypothesis, and the selection of level of significance. So we talk about all this as we move forward. Statistical hypothesis, statement of circumstances in the population that the statistical process will examine and decide the likely truth or validity. So what is the likely truth that what you state will actually happen? That is what statistical hypothesis is about. Statistical hypotheses are discussed in terms of the population, not the sample. So when you are trying to discuss your findings following a research and you tested your hypothesis, so your discussion should be focused on population, not on sample. And why are we saying this? Because the primary thing is that the sample you generated, your aim is for you to go for generalizability. So in trying to discuss your findings, it should be centered on the population rather than being centered on the sample. So based on the mathematical concept of probability, null hypothesis, and alternative hypothesis are the ones that we are discussing. What is a null hypothesis? The case when the two groups are equal, population means are the same. When you say the population means are the same, and you make a proposition that the two groups are not going to be different. They are not going to be different. Let's say gender differences in exercise tolerance. If somebody is trying to check gender differences in exercise tolerance, that's the research. So when I'm going to say the null hypothesis is for me to dispute to state that there will be no gender difference. So which means when I say no gender difference, what I'm trying to say is that male will not be greater than female, and female will not be greater than male. So when I want to test, when I'm testing hypothesis following the result, it's either my null hypothesis will be accepted or be rejected. So when is it going to be rejected? When my findings actually indicated that either male is greater than males are greater than women, or females are greater than males in terms of exercise tolerance. This is the type of hypothesis. This is the hypothesis actually being tested. So when we are testing hypothesis, essentially it is the null hypothesis that we test in a research. Literally, all the researches you'll be doing from undergraduate to postgraduate studies, the hypothesis that is expected that you are going to state are null hypothesis. What is alternative hypothesis? The case when the two groups are not equal, when there is some treatment difference, when other possibilities exist. When we say there will be no difference, well, a hypothesis that stated that there will be difference, there will be direction, male will be better than female, female will be better than men. Those are alternative hypotheses. The HO and H1. HO is what they call the symbol for null hypothesis is HO or H0, and H1, which is the alternative, must be mutually exclusive. When we say null hypothesis, it should be more. You cannot say that null hypothesis is the hypothesis. You have both null hypothesis and alternative hypothesis. You are expected to just state either the null hypothesis or the alternative hypothesis. So generally, the H1 are the research hypothesis. Then the HO are the statistical hypothesis. So let me give you few studies, and probably just one study because of time. And let's see if you can construct a null hypothesis for it. So before I do that, I will say that the hypotheses that always say that no, the word no is the main thing that we consider when we are talking about null hypothesis. For example, for example, when we say what is the effect of exercise? Effect of exercise. Okay, let's say like the one I mentioned earlier. About exercise tolerance. Gender differences in exercise tolerance. Determination of gender differences in exercise tolerance. Let's say the research is, the title of the research is determination of exercise tolerance, or determination of gender differences in exercise tolerance. That's it. So now write at least one null hypothesis. One null hypothesis regarding determination of gender differences in exercise tolerance. What would be your null hypothesis? What would be your null hypothesis when you say determination of gender differences in gender differences in exercise tolerance? Gender differences in exercise tolerance. So what is the likely null hypothesis that you will come up with? You can write it down. We will proceed. So we go to the next one. So there, when we say null hypothesis, we will say there is no treatment effect, or the drug has no effect. So now in the case of determination of gender differences in exercise tolerance, we say there will be no gender difference, or gender will have no effect on exercise tolerance. So what if we want to say the alternative? There is treatment effect. So in this case, there is gender difference. Gender will determine, gender will be a great determinant of exercise tolerance. You can see this is how we play the game. So evaluation of the null hypothesis. In order to gain support for our research hypothesis, we must reject the null hypothesis, thereby concluding that the alternative hypothesis likely reflects what is going on in the population. You can never prove the alternative hypothesis. Alternative hypothesis is not the one that we always test. We test the what we test is the null hypothesis. So when we talk about hypothesis testing, we are majorly focusing on alternative null hypothesis. Oh, Chidima, you actually moved to something different by talking about blood pressure and all that. We are talking about exercise tolerance. So your hypothesis should be centered on exercise tolerance only. I think I've explained this slide. Okay, so we move to the next one. In an ideal world, we would always reject the null hypothesis when it is false. And we would not reject the null hypothesis when it is indeed true. But there are two other scenarios that are possible, each of which will result in an error. So here we are trying to explain the two types of errors that exist in research. And trying to talk about these two errors, it is the hypothesis that guide us towards talking about these errors. We have what we call type 1 error, and we have what we call type 2 error. So what is a type 1 error? What is a type 2 error? So let's go back to this slide, beginning of this slide. You say, in an ideal world, we would always reject the null hypothesis when it is false. What is the null hypothesis saying always? The null hypothesis is always saying that there will be no this, or this so does not exist. So if truly it does not exist, we reject it. I mean, if truly it does not exist, we accept the null hypothesis that yes, it does not exist. But what if it exists? We have to reject it, provided the what we found is accurate. For example, under normal circumstances, we want to test intellectual capability of male and female, intellectual capability of male and female. And we actually subjected now what we are doing currently is a lecture. And what is the likelihood that male are going to perform better in understanding than female? There is no such thing that will be able to tell us that the male of participating there is nothing that is indicating that the males are going to understand it better than the females. There is nothing indicating that. So for this reason, we cannot say that the males are going to understand better than the females. We are only going to assume that they are likely going to understand it equally. So if a study is now telling us that male understand better than female, then the likelihood of that so for us, we will now look at the null hypothesis that is saying there will be no difference in understanding this lecture as being more appropriate than an alternative hypothesis that is telling us that male are going to understand better than female, or female are going to understand better than male. So when we talk about type 1 error and we talk about type 2 error, we are now going to look at when is it a type 1 error? When is it a type 2 error? Type 1 error. Rejection of a null hypothesis that is actually true. What is a null hypothesis saying? Null hypothesis is saying there will be no difference. There will be equal response. Male and female are going to understand this lecture equally. So when we rejection of a null hypothesis that is actually true, male and female are going to understand this lecture equally. This is true. But what if we now reject it based on our research findings? We now reject it. So there is likelihood that we are rejecting a true null hypothesis. In this case, there is what they call a false positive. A false positive. The alpha value gives us the probability of a type 1 error. For example, alpha is equal to 0.05, which is 5% chance of rejecting a true null hypothesis. We're going to talk about this one as well. So, what is false positive? What is false positive? Please write briefly what you understand by false positive. I'm going to give 2 minutes for people to respond to this. Write what you understand by false positive. Write it down. What do you understand by false positive? What do you understand by false positive? Please quickly. Let me see responses. What is false positive? Correct, Mr. Callistos, that is correct. Okay, a false positive is a situation where ordinarily something does not exist, but now your result is indicating that it actually exists. Let me give you an example. In research, particularly those who did those who understand exercise therapy very well, there is what we call stress testing. Stress testing is a common test that they actually use to assess the presence of heart disease. So in women, in most cases, because stress testing is just ability to be able to pass through the stress testing test, you will realize that a number of males will actually pass that test. But many women will actually fail the stress testing. And when you fail the first stress testing, it is supposed to tell us that you are likely having a cardiovascular problem or a heart disease. But in most cases, women will fail this test, but it does not necessarily mean that the woman actually have a heart disease. You can see that it is telling us that she's unable to do the test, and therefore she is supposed to be that's supposed to be an indication that she has a heart disease. But in most cases, women who are unable to do stress testing, most of them have proven not to have any heart disease. But in most cases, men who are unable to do stress testing, a number of them have proven to actually have a positive problem with heart disease. So you can see for female, stress testing can actually be a false positive result. So all tests all assessments that when we do them, they are actually indicating the presence or absence of something when truly that thing is present or when truly that thing is absent. So they wrongly gave us an outcome. We call them false positive result. Now, the alpha value gives us the probability of a type 1 error. In every research, the researcher is supposed to, what the researcher is trying to avoid is an error. Why is he trying to avoid an error? Because in research, we are trying to bring out findings that people can use, can trust, and can believe in. And when they use it, it is supposed to impact on their lives. So if we bring out results, and this result is an error, it is going to be detrimental is going to be disastrous. It may even cost lives. So as much as we can, in research, what we are trying to do is to make sure that our findings are accurate. So in that regard, they now develop a way of saying that what percentage of our results can we allow or can we claim that is not necessarily correct? So the point I'm trying to make here is that what amount of your research or your findings can you allow to be based on error? So that is where they come up with 0.05 alpha level. So 0.05 alpha level is now saying that the percentage of error in every finding that the researcher is presenting is 5%, which means the confidence that the result is not due to error is 95% chances. That 95% chances that the result you are presenting to us is actually accurate and evidence-based. So we are free. So who will now say that I'm not going to use this result, so only 95% of it is correct? No, we can use that result because 95% we are confident that 95% of it is actually accurate. It's only 5% that is not accurate. So that is why they come up with 0.05 alpha level. So we move on. Example. A null hypothesis says that drug has no effect. The newly manufactured drug has no effect. The alternative says there is an effect. They now say reject the null hypothesis and instead claim the alternative hypothesis is correct. So claim that the drug has an effect when indeed it does have an effect. Therefore, the drug is falsely claimed to have an effect. I mean, to have no effect. So if for example, you now claim that the drug has no effect when truly it has an effect, or what I mean is that when you claim that the drug has no effect when truly is that it has an effect, you have falsely laid a claim. So the drug is falsely claimed to have an effect when truly it does not have any effect. When it does not have any effect, and at the end of the day you are claiming that it has an effect, you have committed a type 1 error. What are we trying to say? Somebody manufactured a new paracetamol and he called it PP paracetamol. And he wanted to compare it with the M&B paracetamol. And in trying to compare this, he now laid a claim that PP paracetamol is better than M&B paracetamol, when truly there was no such effect. There was no such gain in PP paracetamol. So he has committed a type 1 error by rejecting a true null hypothesis. What is the null hypothesis saying is that the null hypothesis is telling us that the PP paracetamol will not be different from what? The M&B paracetamol. But now, this person is claiming that PP is better than M&B paracetamol. So, which is a false positive result. So how do we control for type 1 error? Alpha is the maximum probability of type 1 of having a type 1 error. E.g., 95% confidence interval. Chance of having a type 1 error is 5%. Therefore, a 5% chance of rejecting null hypothesis when null hypothesis is true. That is 1 out of 20 hypotheses tested will result in type 1 error. We can control type 1 error by setting a different level of alpha. So when you change the alpha level, you are likely going to control the type 1 error. So if the alpha level is now made to become, let's say, 0.1, 0.1 is 10% chances of error. So you are leaving 10% of your result to be due to error instead of 5%. There is possibility that since it is 10%, then you may not necessarily reject your null hypothesis. You may not necessarily reject null hypothesis, which means the margin is being widened. Previously, the margin is narrow. You have increased the margin. So the likelihood of you having a positive result has increased compared to when you have a narrow margin. This particular aspect may be difficult for some people to understand. You may contact me privately for more explanation on type 1 and type 2 error for those who did not get it. Controlling type 1 error, particularly important to change the alpha level to be more conservative if calculating several statistical tests and making comparison. We have 5% chance of getting significant results just by chance. So if running term comparison, one should set a more conservative alpha level to control for type 1 error. That is what we call Bonferroni correction. Now, if a researcher is conducting a research and the outcome measures he has, they are many. For example, he's having 10 outcome measures instead of having 1 or 2 outcome measures. In this case, the chances of having type 1 error is very, very high. In particular, when he's using a statistical test that he will test this, he will test outcome measure 1, outcome measure 2, outcome measure 3 separately instead of checking the outcome measures at the same time. So the individual is likely going to have, those who understand statistics will probably get this better. The likelihood of that person having type 1 error is higher. So in such a case, he's going to set a more conservative outcome measures. Since he has 10 outcome, more conservative probability level or alpha level. Since he has 10 comparisons to make, 10 outcome measures, he's going to divide the first alpha level that he set. In this case, for example, if he set 0.05, then he's going to divide 0.05 by 10 to get a more conservative outcome, alpha level. When you divide 0.05 by 10, you're going to have 0.005 as your alpha level. And he's going to use this alpha level in checking whether his hypothesis is actually accepted or rejected. Like I said, those who have challenge with this can contact me privately. It is a lot difficult to understand this concept in this kind of, except where we have one face-to-face, it's easy for me to put it on the board and do the calculation, make an explanation for you to understand better than when it is a virtual interaction like this. What about type 2 error? We do not reject a null hypothesis that is false. When a null hypothesis is false and we do not reject it, we have committed type 2 error. Like a false negative. So in the case of not rejecting a false null hypothesis results into committing a type 2 error. E.g., you thought a drug had no effect when it actually did have an effect. You subjected a group of persons to an exercise, and you are expecting exercise to reduce blood pressure. But at the end of your research, you are saying that the exercise played no effect in reducing the blood pressure. So most likely there is an error committed, and that error could be a type 2 error. The probability of type 2 error is given by a Greek letter, which they call beta. This number test denoted as 1 minus beta. This also, like I said, can better be understood by people who understood statistics a lot. So how do we control for type 2 error? Basically, the power of sometimes less formally refers to the probability of rejecting the null hypothesis when it is not correct. Power reject null stroke alternative is true. Accept alternative stroke alternative is true. As the power increases, the chances of type 2 error false negative decreases. Now, what is the power? That is to shift your power, which is usually the power is set between 95%, 90%, and 80% power. That is what we set for our researches. So the lower the power, the lesser you are to fall into type 2 error. Power in the sample size, the lesser chances of having type 2 error. So type 2 error, the chances of type 2 error increases with smaller sample size. The bigger the sample size, the lesser chances of having type 2 error. This is the end of this particular aspect of the issues related to hypothesis testing. Variable, I think we talk about variables, we talk about hypothesis testing, and I think we talk about nominal and ordinal scale. So these are this is what this session is all about. Please submit your questions and make your comments. I will have to go for prayers. If you want us to return, we'll have to return by 4:30, and which means we are going to have only 30 minutes to talk, to discuss. Any question for me? Any comment? I believe this slide is more challenging than the previous one, particularly the area that has to do with hypothesis testing. Any question or comment? Questions to comment? And what is the suggestion? Do we come back in 30 minutes or we close the session? Whichever one is your choice, we go by it. By the advert, it says the session is ending by 5. So I wouldn't like to shortchange anyone. If you want us to come back, we'll come back in the next 30 minutes. Raise your suggestion, please. Quick. 1 or 2 suggestions. I have to go for prayers. Okay, according to Gloria, we can close the session. Any other suggestion, please? Any other suggestion? Please, I'm getting late for my prayer, please. Any other suggestion? Otherwise, we go by her. Oh, minimum clinical difference and how it relates to the statistical errors. This session is for research. If I'm going to go into that, it will take us nothing less than 30 minutes to 40 minutes. Yes, please, the recording, I believe Dr. Samani will share the recording. Okay, Fatima, say we can close. Okay, my email, I will drop my email. Let's see. The recordings, I will actually speak to the coordinator, to all those who subscribe for the 2 sessions. You get the recording for this and the previous one. Yes. Any other thing? That's my email for those who want to contact me. All right. Thank you very much. Have a pleasant evening. Thank you very much for participating, and hope to see you next time when we organize another one. Please, the recording should be sent. Okay. Thank you very much, everyone. Bye for now. Bye-bye. Thank you. So I believe Dr. Samani will take care of sending the recordings. Bye-bye.
Thank you, sir, for the presentation.
Thank you, sir.
Thank you.
Thank you, sir.
Okay. Bye. Thank you.
Thank you, sir.
Well done.
Yeah, let's go.
Thank you, sir.
Please don't stop writing on that book, please.
Follow her. I have a same home. You forgot her phone. Yeah, let's go. I will just go to the gate. I'll so that we meet her. Yeah. Kuma hasn't gone. Nothing breaks here. No.